Well, good afternoon. Welcome to the second half of the Health and Human Services Committee's Day of Interim Study Hearings. My name is John Arch. I represent the 14th Legislative District in Sarpy County. I serve as chair of the HHS Committee. I'd like to invite the member of the committee, we'll have others join us here shortly, to introduce himself, which you may do now.
Matt Williams from Gothenburg, representing Legislative District 36.
Also assisting the committee this afternoon was one of our research analysts, Bryson Bartles. Noah Boger is serving as the committee clerk, and Morgan Baird is our committee page. I will quickly go over our policies and procedures again for those of you who might not have been able to tune in this morning. Please turn off or silence your cell phones. This afternoon, we will hear 3 resolutions. We will be taking them in the order listed on the agenda outside the room. LR 404, introduced by Senator McKinney, will be first, followed by LR 408, also introduced by Senator McKinney. We will conclude with LR 367, introduced by Senator DeBoer. I know both senators have arranged for specific testifiers, but all 3 of these hearings are also open to public testimony. For those of you testifying on any of these resolutions, you will find green testifier sheets on the table near the entrance of the hearing room. Please fill one out, hand it to the page when you come up to testify. This will help us keep an accurate record of the hearing. I'm asking that you limit your testimony to 5 minutes, and the light system will give you an indication of how long you've been speaking. At 4 minutes, the yellow light will come on, and the red light at 5 minutes. These are study resolutions for information gathering purposes and not bills, so there's no record of proponents and opponents. Just as with legislative bills, comments for the record may be submitted online via the chamber viewer page, as long as comments are submitted prior to noon on the workday before the hearing. And with that, we will begin this afternoon's hearings. Senator McKinney, welcome to the Health and Human Services Committee.
Thank you. Good afternoon, Chairman Arch and members of the Health and Human Services Committee. I am Senator Terrell McKinney, Terrell McKinney. I represent District 11 in the state legislature, which is North Omaha. And we're here this afternoon to discuss LR 404, to examine the racial and ethnic disparities within Nebraska's child welfare system. The purpose of this resolution is to examine the racial and ethnic disparities within Nebraska's child welfare system. Research overwhelmingly demonstrates that children and families of color make up a greater percentage of individuals in the child welfare system as compared to the percentages in the national and state general populations. And this is especially true for Black and Native American children and families. Research also overwhelmingly demonstrates that individuals and families of color make up a greater percentage of individuals that law enforcement officials interact with as compared to their percentage in the national and state general population. And thinking about the various pathways for entry into the child welfare system, law enforcement officers have a role through reporting, referring, and assisting child welfare workers in investigating families who come in contact with the system. This study shall examine the disproportionality in Nebraska's child welfare system and if and how the role of law enforcement on the front end of the child welfare system contributes to it. The study shall include, but not limited to, collecting race and ethnic data regarding Nebraska's child welfare population as a whole, as well as specific parts within such system compared to the state's general population. Next, sources of reports and referrals to the child welfare system included, but not limited to, law enforcement officials and the length of time in the child welfare system, including both alternative response and traditional responses in the child welfare cases. 2, an examination of the pathways leading to the entry into Nebraska's child welfare system, including the role of law enforcement officials, the scope of law enforcement's authority, and relevant statutes regarding rules and regulations controlling such entry and such roles. 3, gathering community input regarding the racial and ethnic disproportionality in Nebraska's child welfare system and law enforcement's role within it. And 4, a determination of potential solutions to reduce the racial and ethnic disproportionality in Nebraska's child welfare system, focusing on the pathways of entry into the child welfare system and law enforcement's role in such entry. and examination of the pathways leading to entry into the system. Like many issues, it's important that we begin to address issues within our state further upstream than we have in the past. It's no secret that the child welfare system in our state has had and still has issues that need to be addressed concerning the disproportionate amount of racial and ethnic representation in the child welfare system. It is important to note that these issues were persistent before privatization and before the pandemic. And if we don't do anything about it, we will continue to see these issues. It is my hope that today we start working towards real solutions and not just a bunch of lip service. I'm sure we will hear some that say they're doing a great job or trying. But even so, when you look at the news every day, you look at the newspapers, you look at what's going on in our state concerning child welfare and juveniles, something has to change and we have to do something about it. Our children and their families need real help that is aimed at eliminating poverty, lifting barriers, and improving educational opportunities and outcomes. Solutions that don't wait for kids to commit crimes to get help, offering help to the whole family and not just a child, addressing racism and cultural competency issues. We are in need of a holistic plan. Too many kids are being failed and too many people are in leadership allowing this to occur and would rather not do anything or wait until something bad happens to try to do the right thing. This is a topic that we have to be unapologetic about and save feelings for another day. The child welfare system in the state of Nebraska is horrible, plain and simple. Kids are being lost in the system, aging out without proper support, with families that only view, some kids are with families that only view them as a check and not as a human. Our child welfare system is also being used and our juveniles are being used to currently build an inadequate juvenile justice facility in Douglas County. But at the same time, we have former systems people leaving the system to go create fancy nonprofits to profit off the backs of our kids. In Nebraska, law enforcement has been responsible for an average of 17.4% of the reports over the last 5 years, consistently placing in the top 3 most frequent reporters. Data shows that the child welfare system disproportionately involves and polices youth and families of color, meaning the percentage of persons of color in the system is higher than the percentage in the general population. This is especially true for Black and Native youth who experience higher rates of reporting and investigations than disparate treatment once they're within the system. Despite evidence that Black and Native families are no more likely than white families to harm children. Such overrepresentation grows within each major decision point in the child welfare system, from reporting to investigations, out of home placement, and permanency. And there are many individuals here that will hit on a lot of important facts and notes. I'll say a couple. I won't try to say them all because we've got other people here to say it. But clinicians are more likely to evaluate and report Black children for maltreatment when presenting similar injuries as white children. And that the best indicators of whether a medical provider will drug test a mother are race and class, not medicine. Black children are also about 30% more likely than white children to be prescribed antipsychotic medication and are more likely to live in congregate care settings. Black children are also 3 times more likely to be adopted, 3 times less likely to be adopted than white children. And Nebraska disproportionately ranks the worst, one of the worst nationally, showing Nebraska's rates for every race and ethnicity. This is for Black and Native children. We rank as one of the worst currently. Some feedback from community, I would say, in a study published this year, the Center for the Study of Social Policy studied child welfare cases from 2005 to 2020 in a number of jurisdictions to examine the system's failing of Black families. The study consistently found examples of implicit and explicit biases and discrimination against Black families exhibited by systems professionals, including multiple cases of describing Black fathers are uninterested, not to be trusted, angry, and unable to parent despite evidence to the contrary or none at all. Extra bailiffs being called into court hearings involving Black fathers. A reunification worker in one jurisdiction stating that the number one thing about African American fathers, they are not around. A probation officer, another stating that they did not connect Black fathers to parenting classes because they felt culturally they are not interested, which is far from the truth. And many reports over recent years have shown that Black fathers are the most involved fathers of all fathers across race lines. And again, I just hope that today will spark a real intentional effort and conversation to make the necessary changes to improve our child welfare system for our children and families. Thank you.
Thank you, Senator McKinney.
Yeah.
Any questions at this point? Seeing none, thank you very much. At this point, we would welcome the first testifier.
Good afternoon.
Good afternoon.
I can begin. Hi, my name is Anahi Salazar, ANAHISALAZAR, and I am here representing Voices for Children in Nebraska. Our child welfare system should promote a safe environment for the children they serve. For a long time in Nebraska, families of color, specifically Black, African American, and Native American families, have experienced negative outcomes in the child welfare system. These families are overrepresented in the system from start to finish, and from the stories shared at the town halls, their experiences have been frequently bleak. There is a relationship between disproportionality and disparity. Disparity increases the potential for disproportionality to occur. This relationship is rooted in systemic racism, and it's embedded in the daily practices, most of the time unintentionally, of the child welfare system. Disproportionality refers to the state of being out of proportion. When speaking about the child welfare system, disproportionality is describing the relationship that exists between the proportion of one group being proportionately larger or overrepresented than the portion of the same group of children in the general population. So 15% of children involved in the system were Black and African American, yet Black and African American children don't make up even 6% of Nebraska's population, for a disproportionality ratio of 2.6. Native American children account for only 1% of Nebraska's population, yet they made up close to 4% of the children in the child welfare system, for a disproportionality ratio of 3.9. Even as Nebraska has worked to strengthen our early prevention efforts and reduce our numbers of children removed into foster care, this disproportionality has persisted. Disparity refers to the state of being unequal. Any efforts that focus on disproportionality and disparities need to also analyze the complexity of factors that contribute to their existence, including racial bias, poverty, and the disproportionate need. There needs to be a better analyzation of what is happening to people before they enter the child welfare system. Individuals working for the system need to be conscious of the lenses used to make decisions along any point in the child welfare continuum and how race plays a role. We must own the racial bias that exists in the system, namely that despite equivalent levels of risk, children of color are more likely to enter the child welfare system and more likely to spend longer times in care. Differential conclusions that negatively affect children and families of color and intergenerational trauma. Placement stability can create a better environment for children in the foster care system. With stability, children can develop healthier relationships with their foster homes as well as receive better care from foster parents. Black and African American children had an average of 3.1 out-of-home placements in 2020, more than any other race or ethnicity in Nebraska. Multiple placements can disrupt not only the mental health of the child, but also their race or their education and overall well-being. Almost 1/3 of Native American and Black and African American children are in out-of-home care for 25 or more months. Being away from family for so long can have lasting effects on children. Data repeatedly tells us that that Native American children are more likely to be removed from their homes and to have terminated parental rights. The data gives us these facts in hard numbers, but behind each number is a child who experienced the trauma of removal, the turmoil of instability and placement changes, and the loss of cultural connection, and the legal undoing of relationships and family ties. So what can we do with all this information? Testifiers present here today will propose some solutions and recommendations. In the meantime, from our perspective at Voices for Children, as a state, we can and should support successful reunifications. So keeping children safe and families together should always be the goal. And then reaching timely reunification while preventing reentry into foster care has many benefits. Children do best when raised in a stable family setting. Another proposed solution, support kinship caregivers. Kinship care refers to placement with individuals who have a pre-existing relationship with the child or children. Kinship care helps children with a sense of belonging, and it can reduce the trauma that can be endured during parental separation. These caregivers make incredible contributions, face many challenges, and need help. Thirdly, develop culturally responsive practices and services. We should conduct trainings on defining and exemplifying what is culturally responsive, as well as identifying racial bias and discrimination among child welfare staff and community reporters. Child welfare professionals should be able to identify the unique cultural strengths, beliefs, and practices of each family they work with and integrate that knowledge into the intervention approaches. And lastly, increase investment in early prevention efforts by supporting communities. For children to thrive, our state agencies providing care must build trust and engage with communities. The disproportionate number of children and families of color living in poverty directly contributes to the disproportionality of child welfare system involvement. Every dollar spent in primary prevention, such as food, utility, and child care assistance programs, affordable housing, home visiting, and accessible physical and mental health services, is a dollar saved in the child welfare system. I would like to thank Senator McKinney for bringing forward this interim study, and I would like to thank the members of the committee for your time, attention, and commitment to every child in Nebraska. If you have any questions.
Thank you. Are there questions? Senator Walls.
Thank you. Thanks for coming. Just real quick, one of the things that Senator McKinney said that was probably one of the most disturbing things was that Black fathers were not referred to parenting classes. So working for Voices of Children, do you also find that to be true in your organization? And how do you address it, or how do you think that should be addressed?
We don't have any research currently on or data on that, but from hearing families at the town hall meetings, I would say that is very true. It was a very consensus feeling in the room, and I think there is a lot of racism, not just in systems, but also when confronting people. So that's why one of our proposed solutions was the developing culturally responsive practices and services. And I think that would be integrated into racial biases.
All right, thank you.
Any other questions? Seeing none, thank you for your testimony.
Thank you.
So, next testifier. Good afternoon.
Good afternoon. My name is Allison Durr, ALLISONDERR. I'm a senior staff attorney at Nebraska Appleseed. You all are receiving a full version of our testimony, but we had a lot to say, so I will summarize it out loud for you. As previously testified to, data clearly demonstrates that disproportionality exists in our child welfare system. But concerningly, this is especially so in Nebraska, where our disproportionality rates are higher than the national rates in every non-white category. And in fact, a recent report placed Nebraska in the top 10 most disproportionate states, performing poorly in every single category, being only one of 2 states to do so. It ranked us 4th worst state for Native youth and 3rd worst state for Black youth. But it's really important for you all to understand that this is not because families of color are more likely to harm youth. White families engage in the same behaviors and circumstances that put families of color into the system. They are just less policed and harshly judged. But what we do know is that every stage of entry into the child welfare system exacerbates and makes this disproportionality worse. So first, with reporting, a person decides whether or not to report child abuse or neglect. Nebraska is in the minority of states that requires all persons, trained or not, to report suspected maltreatment or risk criminal charges. And the intent is a better safe than sorry approach, but in practice, it results in the opposite, an extreme over-reporting. The past 5 years, on average, only 5.8% of our reports were found to be true, putting Nebraska in the 10 states with the lowest rates of report substantiation, meaning our over-reporting is much worse than the majority of states. And research shows that over-reporting doesn't actually result in better maltreatment detection or safety outcomes for children, and instead drains child welfare resources on the wrong families and wrongfully traumatizes and investigates families. We also know that because families of color are more likely to be reported, they are the ones harmed and wrongfully traumatized by this over-reporting than brought into the system. Second, once a report is received, the department is to assess it and decide if it fits our definitions of child abuse and neglect. But any scholar on child welfare disproportionality will tell you that these definitions can be pointed to as a great source of disparity because they're so vague and cast too wide of a net. For example, our definition of neglect says a child who is without, quote, proper care or without food, clothing, or shelter, meaning a family can be brought into our system simply for lacking resources. And well over the majority of our child welfare cases are because of that type of neglect, with over 85% of our maltreatment reports in 2020 being due to that definition of neglect. Because families of color are more at risk for poverty, they're more vulnerable for being brought into the system for being low income. They also interact with social service agencies more because they need public assistance, which makes it so they're more visible to be reported for being low income, creating this dilemma where they can either choose to access services and risk being reported or not access services and be reported for not getting help. And then lastly, when the department is assessing a report, it's deciding, is this child safe in their current circumstances? And that question is asked throughout the entirety of the case. But the standards for that are notoriously vague and subjective, and the majority of child welfare decision makers are white, judging low-income families of color. No matter how well-meaning a professional is, human decision-making is informed by implicit biases and stereotypes and their own view of what a healthy and fit family looks like. And unfortunately, research demonstrates that judgment results in disparities and disproportionality, and child welfare decision makers wrongfully assuming families of color are more unfit from the start and all the way throughout the end of the case. I think the good news here, though, is that scholars, advocates, and community members have proposed a lot of really clear, concrete policy solutions that Nebraska could and should pursue to start to improve this. This includes amending our reporting requirements, amending our neglect and abuse definition. It includes adding race and equity checks throughout the reporting process and assessment process. It also includes the legislature or this committee doing race and equity assessments of every child welfare policy pursued and requesting race and equity data, and of course, including community members of color in all of these conversations, especially tribal partners. Whatever solutions this committee chooses to pursue, action on this is long overdue and well-deserved. Families of color are being disproportionately traumatized by our system. The child welfare system is meant to rescue children that have been harmed, but in this case, the system is what's doing the harming. So we thank Senator McKinney for his time on this issue and thank the committee for your attention, and we encourage and implore action.
Thank you. Are there any questions? Senator Williams.
Thank you, Chairman Arch, and thank you for being here. You used the term early in your testimony of less policed and more harshly judged. Can you give me some further explanation on the less policed comment?
Absolutely. I'm glad you asked that. So law enforcement act as as the kind of on the ground ears for the department. They are the ones in the community acting or interacting with families. We know that families of color and communities of color, and especially environments that are more low income, are more policed, meaning law enforcement are more present in those communities for various reasons. And so they are interacting and surveilling with families of color more than white families. And in those interactions, because they are mandatory reporters, they're in a position to have to judge the circumstances and situation the child finds themselves in. And so because they are interacting with families of color more, they are surveilling and judging them more than white families, meaning they're more policed. And when we say the word policed, we can think about when you're brought into the child welfare system as parents and families, you are being charged with offenses. You're being charged with child abuse or neglect. And so you are facing legal consequences for the circumstances that your family and child finds themselves in.
You also talked about over-reporting with the Black and Native community. Who is doing that reporting?
So like I said, in Nebraska, every person is a mandatory reporter. So professionals and non-professionals alike. But in Nebraska, our top 3 categories of reporters are school personnel, law enforcement personnel, and then relatives and friends. But a lot of the research talking about Black families being overreported, one of the studies Senator McKinney referenced, in fact, law enforcement and medical personnel are especially susceptible to overreport Black families.
Okay. Not sure quite how to ask this, but I understand disproportionality in what we're talking about here. And we're talking about potentially over-reporting the Black side. Is there any fear of under-reporting on the other side that would balance the equation?
I don't know if I would say underreporting, but there certainly is a lack of balance in the surveillance, like I talked about, of white families. And so because white families are less at risk for being low income or being impoverished, they are less likely to interact with people who are going to report them. And even if they do interact with folks that would report them, studies show they are less likely to be judged, or their environment is less likely to be judged to be unfit. So that is likely what results in lower reporting for white families, but I don't know if I would say it's underreporting.
Thank you.
Other questions? I have one, just a second here. I want to go back to the question of over-reporting, because you said only 5.8% are found to be true. So that's obviously the average. Have you taken a look and seen what the Black community, that percentage would be compared to the rest of the general population? Is it the same? Has there been research on that?
Yes, absolutely. And I don't have the numbers directly in front of me, but I know Voices for Children, the Nebraska Foster Care Review Office, and then also the Child Abuse and Neglect Reports the department puts out every year does break down that information by race. And just from my recollection, it is disproportionate for Black youth, but especially disproportionate for Native youth. And so the over-reporting is worse for those populations. But also something that skews that data just a little bit is that those reports are also more likely to be found substantiated or true, not necessarily because maltreatment is more likely to be true, but because of the biases that go into the decision-making of deciding to substantiate it.
Okay, thank you.
But like I said, the data does exist.
All right, thank you. Any other questions? Seeing none, thank you for your
Thank you.
testimony. Next testifier.
Hello.
Hello, good afternoon.
Good afternoon. Thank you. My name is Deborah Dancer, and it's Deborah, last name Dancer, like the reindeer. I'm with Douglas County Community Response, or DCCR, serving as the Chief Administrative Officer and functioning as our community collaborative leader. So DCCR collectively, through community response, has served over 1,000 families indirectly, serving over 1,200 children. Housing was number one need, with the average request just over 1,000 per request and representative of 62% of the dollars invested. Next, utilities at about $450 per request, representing about 25% of the dollars listed. And these concrete supports include coaching and supplemental support such as care portal and child care referrals and opportunities. A little about the 1,068 families served through community response. Again, there were 1,268 children indirectly strengthened through that. We are working collectively to disentangle neglect from poverty and prevent entry into the child welfare system by focusing on child and family well-being. It has changed how we work since our formal beginning in 2015. Our work is data-driven, and we focus on reducing the number of screened-in calls to the CPS hotline. Indigenous, Black, and Latinx families are overrepresented in screened-in calls for neglect through the CPS hotline, and the same families are overrepresented in substantiated cases of child abuse and neglect. The data shows our top 3 reporters, again, this is in Douglas County, are in the sectors of education, medical, and law enforcement. The data also showed us that Douglas County contains the top 5 zip codes of those calls, and we have purposefully concentrated our work there. And it happens to be in North and South Omaha, in the zip code specifically of 68104, 107, 108, 110, and 111. We are simultaneously evaluating our process and progress, demonstrating that this investment in families who have been minoritized and marginalized deserve opportunities to choose opportunities that strengthen them. The overrepresented populations in the screened-in calls in Douglas County have received concrete supports through central navigation and coaching. Those who like data and results may appreciate that of those we served and impacted, impacted by overrepresentation received the services intended. So Indigenous or Native American families were represented in our work at a rate of 2% in comparison to the larger communities served by the collaborative of 1%. Black or African American families at a rate of just over 44% in comparison to the larger community served by the collaborative of 11%. And almost 15% for Hispanic or Latinx families in comparison to the larger community served in the collaborative of 13%. This tells us that we are reaching our impacted families, but also that there's more work to be done. Our vision is to inspire and mobilize a community response prevention system where children in Douglas County, Nebraska, have a safe, quality family and community environment. We are also doing a national project, 2 national demonstration projects that will allow us to make this scalable. And we are working in conjunction with other communities, other community response organizations all throughout Nebraska. Now, our system consists of community response, central navigation, coaching, and has 17 partnering organizations that provide coaching and over 79 member agencies that meet and work collectively to advocate and further our community response to reducing child maltreatment. The strategies we use in our demonstration projects are collective impact, community response, communication, staff training, care portal, which is access to faith-based organizational portal that supplements central navigation resources, and community cafes, which are parent-facilitated conversations with parents. A few critical values that shapes our work and is our commitment to promotive and protective factors, knowledge of parenting, child and family, adolescent development, social and emotional competence, concrete supports, resilience, social connections, and this framework is like social determinants of health. It is a space to use similar language, acknowledge where we align and intersect, and continue to be inclusive of community when we are working collectively. We have a system-wide commitment to promotion of equity, where we create and amend foundational goals and outcomes and establish context for lived experience labels in conversations, and also maintaining our planners and achieving the highest levels of shared power. There are other things that we do, and obviously not enough time to tell you everything that we do, but we wanted to make sure that what we'd like to see continuing in our work is having more collective community work, and then also making sure that we're working together on our training suite. And that is like working on advocacy training, mental health interpreters training, before the call to CPS training to give reporters and practitioners another option to address poverty disguised as neglect for families that they serve or observe. And that's pretty much it.
Thank you. I have a question. Help me understand. It seems as though your focus is really strengthening the family.
Mhm.
Where and how, when do you receive a referral to help a family?
We are at the prevention end, so we are before. So this is ideally how it would work, is that individuals, people who we're working with would make a call to us first, and that would be through central navigation. That's the idea. That's the point that we want to make. Unfortunately, we've been working behind the scenes for a long time. That's probably why some people haven't really heard of us, but we didn't want to be the showcase or the front and center individuals because it is a collective. So now we are having the training where we're working with the mandatory reporters to really help support the effort to be mandatory supporters versus mandatory reporters. We're not taking away from reporting, but just giving other options. So we have built up through our communication team a website so that people can get to us right away, but we recognize that not everybody has access to internet. So we're just equipping everyone to maybe rethink how they're coming to us and this collective work. And it's not just us, it's other communities, but I'm here representing Douglas County.
So let me summarize that a little bit differently. So your belief is that there could be some reporting that's going on while not necessarily, I mean, I know that the department says report, we'll decide, right? But your belief is there could be some reporting going on that isn't necessarily meeting that clear definition, but they know the reporter knows that there's going to be something that will happen to help the family or to intervene. Yes?
I'm going to say yes and no. The idea is yes, they're thinking that that's going to happen, but we have these
Well,
discussions in
that's
this
a
group.
different issue, right?
Well, what they're saying is there's some frustration from some of the reporters that
Right.
it's going in, like let's say for instance from educators, that it is going into the CPS hotline, but it's not worthy of a
Right.
report, and that's all that happens. And so sometimes
I see.
there may be referrals onto services, but there's many that get missed.
Yeah.
But that point is that they may very well be entered. That's where the over-reporting comes. There's theories with families that if there is knowledge on how to come up with solutions and they're part of the solution, we're hopeful for that.
Thank you. That's very helpful. Any other questions?
I just have
Senator
a
Walz.
question. Is it a hotline that you have? Do you have a hotline or?
We have a website.
Website.
Yeah, so we're
Okay.
trying to be careful not to step on the toes. DHHS is one of our partners, and
Uh-huh.
so we're just trying to work with them. We're trying to work with the family helpline as well. And ours is central navigation, and so they're regular business hours. So those aren't emergency help, but we are partnering with emergency help, like let's say homelessness, and we would work with our local continuum of care.
All right, thank you.
Other questions? Seeing none, thank you very much for your testimony. Next testifier. Welcome back.
Thank you. Get my glasses on. Chairperson Arch and members of the Health and Human Services Committee, my name is Monica Gross, spelled MONIKAGROSS, and I am the Executive Director of the Foster Care Review Office. And I'm here today to provide some data on children in out-of-home care in Nebraska. We have a problem with disproportionality in our foster care system in Nebraska. It's not a new problem. And there's a chart in your packet that shows over the last 4 fiscal years, the rates of children in the general population divided by race and the rates in the foster care population. I won't go through that in my testimony. It's in your packet, and one of the previous testifiers already spoke to those figures. In the spring of 2022, our agency launched data dashboards on our website. The dashboards contain point-in-time data from the last day of the previous calendar quarter, the same data that's reported in our quarterly reports. Our most recent quarterly report was electronically submitted to the legislature yesterday, December 1st, and the data that I'm about to share with the committee comes from that report. One of the distinct advantages of using the data dashboards is that the point-in-time data can be filtered in various ways to give the user more insight into the subpopulations of children and youth in out-of-home care. Because disproportionality in child welfare is such an important and pervasive topic, we believe it's important for us to share these data insights with the committee and the public. Our quarterly report contains a special section, which is part of your packet as well, breaking down the data related to children in out-of-home care, including by service area, age, gender, and race and ethnicity. We looked at outcome measures related to time in care, number of caseworkers, number of placements, and children missing from care. These measures are all related to stability and well-being for the children involved. Our study showed that children of color are represented in foster care at disproportionate rates, that these children spend more time in care, have more placements, and more case managers. Other studies have shown that the more case managers a child has, the more time they spend in foster care, and that caseworker turnover was correlated with increased placement disruptions. Our study looks at these factors broken down by age, gender, and race. On September 30th, 2022, there were 3,633 children and youth in foster care in Nebraska. This figure includes only children who are in the care and custody of the Department of Health and Human Services and does not include youth who are under the supervision of juvenile probation. For those 3,633 children and youth, the median days in out-of-home care on September 30th was 457 days, roughly 1 year and 3 months separated from their families. The average number of caseworkers for those children was 4.3, and the average number of placements during their most recent episode in care was 2.8. When we break that down by gender, we find that boys spend slightly more time in foster care than girls, 20 days longer. When we break it down into age groups, we find that 13 through 18-year-old youth had the longest median days in care at 550 days. They also averaged 5.1 caseworkers and 4.6 placements. Next, we filtered the data by race and age and found startling differences by race. Black non-Hispanic children had the longest median days in care, the highest average number of caseworkers, and the highest average number of placements. Black non-Hispanic children spent 661 median days in foster care, had an average of 7 caseworkers, and 3.9 placements in their current episode. Similarly, age group filters revealed racial inequities in every age group. For example, for ages 0 to 5, the median days in care was 353 if the child was white, and 547 if the child was Black. For those children ages 6 to 12, the median days in care was 381 if the child was white, 681 if the child was Black, and 623 if the child was American Indian. For ages 13 through 18, the median days in care was 497 if the youth was white and 852 if the child was Black. When we further filtered by race, age, and gender, we found that Black non-Hispanic teenage boys had 1,061 median days in care, and Black non-Hispanic teenage girls had 792 days in care. Both groups had the longest median days in care compared with other race groups of the same age. Black non-Hispanic teenagers had the highest average number of caseworkers at 9, the highest average number of placements, and the highest rates of being missing from care. When we look at just the Eastern Service Area in particular, we found that American Indian non-Hispanic children have the longest median days in care at 856, and Black non-Hispanic children had the second longest median days in care at 758. White children in the ESA had median days in care of 519. Thank you, Senator McKinney, for introducing this interim study, and I want to thank the committee for listening to me today. I know I threw a lot of numbers at you. I'd be happy to answer any questions.
Thank you. Are there questions? Senator Williams.
Thank you, Senator Arch, and thank you, Ms. Gross, for being here and sharing that information. I want to go just a little bit deeper because I think the numbers point out the disparity. The question is why? And from your judgment of looking at this and analyzing this, is this what I would call or define as systemic racism that is underneath this, or the term I would continue to use or also use is institutional racism?
I don't know
I
that.
just went in the weeds with this. this.
Yes.
That's
and-
where I
and-
wanted to go with that.
Right, right. And to be sure, we don't have data looking at, the entire picture of what happens. You heard a lot of testimony already about the front end of the system and children entering, and we don't have any data on that. What we can tell you is that once a child enters foster care, out-of-home care, Black and Native American children stay longer than white children, quite a bit longer, as you heard. I think we need to look at what our structures and our institutional practices are that perpetuate that. This is not a new problem, and this is just one point in time. But I think we do need to look at those through a race equity lens to determine if, as your question asked, if there are structural or institutional racism factors that play into it.
Thank you.
I've got a question for you, because I know you've obviously been on both sides. You've been on the provider side as well as now the FCRO. What you heard earlier testimony regarding over-reporting. What's your thought on our current reporting system, and is there, and I'm not even asking necessarily bias on over-reporting, but is there over-reporting going on, and is that a bad, well, maybe that's a judgment call I won't ask you to make, but what's your thoughts on over-reporting?
Well, I think that there are a lot of reports, and I'm familiar with some of that data. Our data shows that 67%, I believe, of children in out-of-home care are in care due to neglect, which can be a broad range of different things. So, I mean, that would suggest that there are a lot of reports coming in related to neglect. And if an issue in a family can be resolved without removing the children, that is preferable. That's more desirable, obviously, than removing the child. Because once the child is removed, and I think particularly we need to consider when we're removing Black children and Native American children, what that looks like for them down the road. We're talking about 1,061 days in care, potentially. And, that's nearly 3 years. And that's the median.
Thank you. Senator Wolf?
Thanks for coming today. I just had a question about the caseworker, the workforce, and the diversity. Do you have any data on how diverse that workforce is? Example, the percentage of white caseworkers, percentage of...
Yeah, we don't. You'd have to get that from DHHS.
All right, thanks.
We know when a caseworker for a child changes, but we don't have any demographics on the worker themselves.
All right, thank you.
Okay, any other questions? Seeing none, thank you for your testimony.
Thank you.
Next testifier. Welcome.
Hi. My name is Majie Miller Jenkins, MAGHIEMILLER-JENKINS. Forgive me if I do this wrong. This is my first time coming up and testifying at Senate. So I had a whole thing prepared, but time constraints and the way it happens. But the reason that I believe I was asked to come and testify today is to give you a little bit more of a person experience as opposed to just numbers. There have been a couple of people that came up and gave you some really good statistics on the state of the HHS and what CPS looks like. I'm here to give you a personal account of how it feels. When I was 12 years old, I was abducted by my aunt and my cousin, kidnapped, and moved through about 13 different counties in Nebraska. When we ended up 4 months later, stopping at David City, all of the counties that I had been through said that they didn't want to hold up the kidnapping charge because they would have to press charges and do the whole jurisdiction process with that. And so they deemed me a Black runaway. And that was the beginning of the end of my adolescence. I lost my entire adolescence to the troubled teen industry. So from 12 to 17 years old, I have been in every Cedars in Lincoln. I've been into 2 in Omaha. I've been to CAPS. I've been to Utah Holly. CAPS is a abbreviation for the Child Adolescent Psychiatric Services, because when you are a Black youth inside of the CPS system, from my experience and from many people that I have worked with, I've worked with in the area of people with disabilities for 10 years. I worked as an advocate in the schools as a para for 3 years. And then the last 2.5 years, I've been doing mutual aid in an alternative foster care. So foster care that's not foster care. I don't work with the state. I don't get funded. I don't get grants. I take children in, and young adults between the ages of 16 and 20, and I provide them with a step towards the next step of what their life can be, free of charge. I get them hooked up with whatever services that they can have. I help them through school. I get them through doctor's appointments, and that's all just me because of how traumatized I was from the CPS service. When I was 14 at Utah Holly, I was sexually propositioned by one of the staff member there. I was told I could run away, that I wouldn't have to come back to that facility if I was pregnant. It was an all-girls facility. There's no way for me to get pregnant other than the staff member there. He told me he would help me out and he would get me pregnant so that I didn't have to go back to Utah Holly. Yep, banged on the window, called in another staff. That man worked there until last year at Utah Holly because nobody says anything. I am a product of silence. We are taught at a very early age as young girls, especially young Black girls, don't rock the boat. Be quiet, be good, do what you're supposed to do, because then when you grow up, you'll get everything that you deserve. It's not true. It's not true for them. It's not true for the youth now. It wasn't true for me back then. And it's a conversation that I feel in rooms with people that have the power to really affect change. They need to be thinking about things like this. Yes, they'll give you a lot of numbers of thousands of Black children who are put inside of CPS. What they won't tell you is how bad it is to deal with those CPS workers. The CPS workers are understaffed and overwhelmed. They don't have time for you. They don't have a bearing on your life either. They're not culturally competent. A white worker going into a Black household would think that I was loud and aggressive, that depending on the types of food that I ate or the types of food that I have culturally in my home, they might say that I am undernourished, malnourished, because the type of food that I have is not consistent with what they consider healthy or necessary. That happens in a lot of cultural settings, but especially Black, Brown, Indigenous, BIPOC households. My other personal experience that I think would be extremely relevant here is the work that I do currently, which is with the youth and young adults. In the last 2 years, I've served about 25 people through my home, still serve about 15 of those people, but none of those 20 or 25 people are gone, because with foster care, what happens is you age out, you end, and then you're left with no one. If you got ripped away from your family and you lost those ties, when you get done, you don't have anybody. You're literally on the streets, and poverty should not be a criminal offense, but poverty is something that the CPS system will eventually tie into a charge. I have a girl that I serve that has her 3 children got taken away because a nurse at the hospital decided that she didn't come up to the hospital to visit her baby enough. She had 2 other children at home and she couldn't go up to the hospital, but the nurse turned her into CPS, and we dealt with a CPS case for 4 months, which ended up resulting in her losing her children because she was poor. Not because she was neglectful, not because she was abusive, not because of anything else, but they deemed it neglect because she's poor. We get hurt, ripped away, and abused by a system that was not built to serve us consistently. And it's not our fault. But thank you for your time and listening to what I have to say. And thank you for Terrell McKinney for bringing this up, because it's an issue that I really, really hope that we can find some solutions for, because my people need help. Do you have any questions?
Thank you for your testimony. Are there any questions? See none. Thank you very much. Next testifier.
My name is Frank Bailey, Frank, last name Bailey. I'm a trauma therapist in Omaha, Nebraska. I've listened to all of the numbers, and I know that just based on the experience. If you talk about just how somebody comes in contact with through police contact, there was one that was just hit the news in Omaha during the winter. I do some trauma work at a drop-in center in South Omaha. The lady was Native. She had her baby on the street. Her last name's Shakespeare, you know, and come to find out, she has intergenerational trauma. She has childhood trauma. The child she had was due to a rape, and she lived on the street homeless along with mental health. Right now, that lady's serving 2 years in prison, and I don't know where her child is at. When you talk about just contact through police, that's all that happened. And you would think just through our legal system and professionals we have, somebody would say, hey, this woman has some mental health issues going on. It's just not normal for anybody to have a child on the street like that. And she was living on the street. But that's an example of what Senator McKinney was talking about. I have a private practice in Omaha, Nebraska. I have a IOP setting. Majority of women that come into my IOP setting through CPS is through police contact. Marie's client I have came in contact with her because she was in an abusive relationship, domestic violence. The guy held her hostage, he choked her, and so many different things. And so when you talk about somebody who's an antisocial personality, they're pretty manipulative. So how could he inflict continued pain and suffering on this woman? Well, I'll contact the police and say, hey, she's a bad mom, these are things going on. And so all her kids were taken. So she has complex trauma. She's dealing with the system, trying to get her kids back. And it was through a man who, with domestic violence, continues his domestic violence because of how CPS treats her. And the only thing my only job is to help people process trauma, live with the pain that they're dealing with when it comes to dealing with CPS, so they get to the other side and get their kids. I have a few young men that I have in therapy. I'm a Black therapist. I'm the only Black therapist in Nebraska that does EMDR. So you would think that I would have a lot of referrals from CPS from anybody in the system. You know how many I get? 0. All my referrals come from people on the street. I'm working with somebody who tells somebody else that, hey, you need to send your kids or you need to go over and see this man. So when I hear the numbers and what's going on, it's pretty mind-boggling. I have 20 years worth of experience. I have 10 years worth of education. I use the latest intervention when it comes to emotional regulation, develop emotional resiliency. So you would think the system would be beating down my door, but it doesn't. The reason why it doesn't, when I'm working with a client, I advocate for the client. I don't allow the trauma that the system creates to continue to traumatize the client in a team setting. I advocate for the client to try to protect the client. And so because I do that, I don't say I stand up and get mad, but I try to divert the conversation to another way. But because I'm like that, I don't get the referrals. So the system is very broken. It's almost like what you're talking about, that it's a pipeline for people to end up in prison. And probably the worst thing I've seen that the system does when you're talking about entering through police contact, there's women that lose their kids. Does anybody know what happens to the women after they've lost their kids? They're thrown away like yesterday's trash. They become sexually trafficked. They end up in prison. They end up with mental health conditions, all because of what is going on. And until something's changed, it's continued to go on. You know, I'm just trying to bring a perspective from the voices I deal with, because I carry their experience with me, inside me. And there's nothing that I can do. I know how I'm treated by the system, but the thing is about saving lives. And I think Terrell McKinney, because I think he's beginning to see it's about saving lives. And I tell by what the senators are listening to, they're interested in the same thing. It's the 21st century. It's time for us to make a difference. And I want to thank the senators for the time. That's all I have.
Thank you. Are there any questions? Seeing none, thank you very much for your testimony today. Next testifier.
Good morning, Senators. Excuse me, my name's Tanya Ward, and I wear several hats. I'm an elected official, sit on the learning community. I'm a nonprofit 501c3 owner, energy rescue, and I'm a mother of 3 sons.
Could you please spell your name for us?
Tanya Ward, Tonyaward. and I live at 4826 South 19th Street in 68107 zip code. My children and I have been through a number of horrible CPS situations. Our personal experience with back-to-back shutoffs by OPPD and MUD at our home and at our neighbors in our communities. We suffered at the hands of CPS cops along with many of the 10,000 families who were trapped by the goals and the false truancy law that was passed using false premise that Nebraska had a truancy crisis, which is a bold-faced lie created by Ashford and Klein, the criminal devils, who made attendance days equal to truant days. The truancy law is a disgrace, and it's still very dangerous and continues to plunge children and families down the thriving Nebraska school prison pipeline. Recent events show Nebraska, there are very serious reasons to stop using school attendance issues to punish our children. Several superintendents decided to stop using goals in their truancy districts, goals truancy program in their districts, and the entire learning community, which I sit on, voted in our last meeting to stop funding the goals truancy program. So hopefully that will bring eyes onto the truancy law. I brought you today solutions. If utilities are shut off in a home where minor age children live safely and are not abused, when CPS and cops arrive at the home, they should bring all the money and resources available to help restore and pay those utilities, provide whatever services that family needs to keep the family whole and intact. But instead, Nebraska steals our children and dumps them into the unnecessary foster care system. That's why it's bulging with too many Black and brown children. PTSD and stress can truly debilitate us, and it has emotionally and mentally damaged all of us. I'm sorry, I'm hopping around. When children are removed from their homes under housing conditions, only cops keep those details. I spoke with the Foster Care Review Board, and they told me they don't track the reasons why kids are brought into the system when it just says housing conditions. That can be from utility shutoffs, it could be from a number of things. But instead of that not being in the child's file once they're in foster care, it should be there. I've seen horrible CPS caseworkers. Tad Evans is a CPS caseworker who tried so hard to destroy my client and her young niece that she was trying to be the foster parent of. He lied about my client. He asked her inappropriate questions out of my presence, like, so do you watch porn? He was very rudely sabotaging all of our meetings as I was the advocate for the CPS case. And he did many inappropriate things with the little girl that were reported, but he had no repercussions and he wasn't punished. When this was reported to the supervisor, they did nothing. Even after years of complaining about Tad, I learned yesterday that this horrible CPS caseworker was promoted and paid even more money now to sit on the Foster Care Review Board. Oh my God, I could have just thrown up hearing that yesterday. I feel sick. Part of the problem is DHHS and CPS and whoever's the new name to take over the foster care system is crawling with horrible caseworkers who have complaints about them, but nobody does anything about it. When someone brought up about Black children being put in homes where their ethnicity and their culture and their heritage doesn't matter. For example, little black girls and boys have hair that requires effort and proper products to keep their hair soft and manageable. I can't tell you how many little Black children I saw in foster care with unkept hair, unkept skin that just required some simple lotion and some conditioner every day. And it's all about truly caring about the welfare, mental and physical conditions of children in foster care. But too many foster parents, it's just a paycheck. A solution is CPS can provide these children with a special backpack with toiletries for their hair and educate those foster parents who are not of their same race how to take care of them. One incident that's really frustrating to me is there is a practice of Nebraska foster parents to kick the kids out at 19. They don't have anything, no belongings. They don't have anything. They're just kicked out. I took in a 16-year-old child who was a foster care kid. When he turned 16, the family kicked him out of the house. They used to lock him in his room when he went to the house. So many days he spent at my house because he was my son's friend. The boy turned to the parents and said, "Can I get my things, my belongings?" And the foster parents said, "No." those aren't yours. They're for the next kid. Get out. So he's 27 years old today, and CPS totally lost track of this child at 16, but he knew he could always come to our house. I never knew exactly where he was, but if he needed something, he came to us and we took care of him. So I thank you for hearing my heart. It's so hard for me to talk about all this pain, but Nebraska should have a state logo that says, if you're poor, prepare for lots of pain and injustice, and that's the truth.
Thank you for your testimony. Thank you for coming today. Are there any questions? Seeing none, thank you very much.
Thank you.
Next testifier for LR 404.
The Lord, and I thought,
The chair's kind of low, isn't it?
it is.
I know. And it's not adjustable either, by the way. We face the same frustrations.
Good afternoon. My name is Jaquela Yarbrough. I will spell that Jaquula. Last name is Yarbro. I am the founder and CEO of Compete Technologies. We are a predictive analytics firm in North Omaha. I also am founder and CEO of I guess I'd be the ED of our nonprofit. It's called the Compete Institute of Socioeconomic Policy and Education. Now, I'm a data person. I just like numbers. I like to work with kids. I like to work with families. I like to look at data and say, hey, here's this predictive model. And if you want to achieve this in 18 months, 24 months, 36 months, this is all you have to do. And that sounds very, very simple, except we live in Nebraska and we happen to be Black. And so I have notably worked with, we are the race equity consult for contracting through Nebraska Children and Bring Up Nebraska for the national movement, Thriving Families, Safer Children. So we're very aware of the Douglas County Community Response. We also partner with not just them, but I'm going to say 22 other collaboratives in the state of Nebraska to provide race equity consult. We are primarily, like I said, predictive analytics. And it is very, very tough. To get straight to the point, our proposal has always been oversight and accountability. The dichotomy of the Department of Health and Human Services is one that I don't think any one person created. However, due to the systemic developments, what we would call, I would call it corporate culture, because I think a lot of my counterparts and partners are comfortable with that term, but it is systemic racism, to answer your earlier question. We have partners to support that research, such as the Burns Institute. They're part of this national movement. They've been providing some resources to us, as well as Evident Change. Evident Change reviews the structured decision-making tool, which is what the department uses to decide what should happen when they get a call, right? If abuse and neglect is reported, they have a manual that says, hey, do A, B, C, D. What is pronounced, even as recent as, I would say, November, which, I guess was 2 days ago, is a new report that comes out to show this data is, the disproportionality of Black and Native children in the system and the outcomes it's enough to get national attention. I would say that. To answer, I don't know if it was yourself, Senator Walls, or Senator Williams, one of you guys asked about the racial demographics of the CFS workers. I don't have current numbers on that, but I do know that in 2020, 2021, CFS released a report to show that for every 23 Black employees, they had 25 Hispanic employees, but there were over 300 white employees. I think the department has taken some steps to say, we need to reform, we need to change. There's a family first prevention going on. There's a strategic transformations going on, all of which are not very equitable. And I do mean that's why we need this investigation into dichotomy of the department, because the child welfare system is really a cradle, which serves as a dragnet for Black kids in education, in housing, in the juvenile justice system, and then eventually going into the prison system. We focus on causal data, causal versus causal correlations, I want to say, and not to get too technical, but A lot of the data, well, a lot of people say that they are data-based. What we have been charged with is, because we're actually data scientists. So we take a look at, is that a transaction within the data? What does that data actually tell you? Are you getting, like you said, why are these reports happening? Why are these students being brought into this dragnet? That data is there. What we look at and what we have been advocating for is the lived experience, the qualitative piece, which has been largely controlled by child welfare and their partnering agencies. So what we're proposing is, upon an investigation into the dichotomy of child welfare and their control and the ultimate perpetuation of disparities for people of color, that you also appoint, and perhaps an amendment of LB 1173, that there be a community board that is not selected by the department to act as an oversight and accountability committee that has authority. But also we would advocate for authorities given to the Foster Care Review Office, because as the Foster Care Review Office does a great job, they make great recommendations, but the department does not have to adhere to that. So I could go on for days, but please ask me questions.
Thank you for your testimony. Are there any questions? I just have one.
Yes.
Tell us a little bit about the company that you were talking about. You've got an IT company.
Yes. So Compete Technologies, we actually started in 2013, and we were an after-school program. So we saw the data that showed that Black kids were just underperforming in school, on ACT, everything, right? We said, okay, we'll start with college prep. So in 2013, we partnered with 5 schools in Omaha Public Schools, and we're able to bring up ACT scores. We also were part of making that mandatory, because students used to not be mandated to take ACT, right? So with the changing of administration, a lot of those priorities changed. And so we had to pivot and do more service-based opportunities within the schools. And so Compete Technologies, we started just being an ACT prep program. What we noticed was all of our students ended up going to jail. All of them, probably 98% of them. And so because I ended up going to court for my students, because some of them, their parents had to work or they didn't have transportation, I actually formed a great relationship with the judges. They helped me to become a juvenile probation provider, so that these kids could still come and get our services, and then we would be compensated for it. Tough part is, we haven't since 2017 received one referral from juvenile probation. And so, again, the dichotomy of the department is something that we're very, very interested in. There has to be some oversight there, because they're tentacles, and I hate to say tentacles like an octopus, but I'm very, I guess, illustrative. But I would say that there is a need for some reform. I don't think that we have mandated players at the table that can get this done. So we can be opportunistic. We can be, as optimistic as we want to about this. But what Compete has identified is from education to child welfare to even housing, and especially juvenile justice, which is where all of our kids end up. So much so that we have an underutilized facility, and we just built another one that we don't even need to put kids in. That is, the cells are the size, the holding cells are the size of, are smaller than solitary confinement. So that's a whole nother thing there. But what I could say what we do best is we serve as sort of like that central navigator. We're actually in the community, and people can walk through our doors and get that support. So if they need to, sometimes families walk in and say, hey, I got this court order, what do I do? Well, first off, you need to go to court, right? We help people to understand their court orders. We help them to understand what their rights are, because they do have rights in the state of Nebraska. And it's not necessarily, dictated to them. So we see a lot of our families go to court ill-prepared, if they go to court at all. And so there are very small reasons for why these families are losing their kids and staying in the system longer. That's just a very small part of what we do, but we're really kind of a one-stop shop in the community.
Well, thank you. Thank you. It's very interesting. Senator Wells.
One quick question. You mentioned a community board oversight that's not part of the department. Can you expand on that? Like, what would you envision this community board to do? What would they be doing?
Absolutely. So the currently With LB 1173, the department has, there's like a tri-head that oversees complaints within the department, any reform within the department. But it's supposed to be part of the strategic transformation movement that's going on right now within the department to address the disparities and develop better community relations. The problem is they were able to handpick the organization that was like the non-departmental oversight that's a part of that team. And so what needs to happen is, there needs to be a community board of individuals, like I mean, shameless plug, like myself, like our senators, like the individuals who are in this room, because we are frontliners, we're on the ground. Those who would normally lived experience individuals who I'm seeing being brought to the forefront in this work, the level of policy development, procedural development, their level of understanding in that area is not one that's conducive for success, right? And any progress in that area. And so we need people, we need the opportunity, first off, to be in the room. First off, there should be a room, but since there is a room, we need the opportunity to be in that room, to represent people, and to really have that qualitative piece added to the data. Because that community board is who will, for one, we're hands-on with the community. We know what our problems are. We know what our cultural norms are, and we're acquainted with one another. I think what's very important too to take a look at is those who are within the department, who are Black, who have some authority or notoriety, don't have any community ties because they were recruited from outside the state of Nebraska. And so I think that the community board of homegrown individuals needs to be probably application-based, maybe people who submit an application to you all or a body that you guys would appoint to do so. I think that it should not discriminate based on their criminal background, because if they're interested in this, they might have a criminal background and they may have had their kids removed. Those are all things that currently prevent families from advocating for themselves with a lot of the ongoing efforts without naming them specifically. If you have a criminal background or if you've had your kids removed or whatnot, there are individuals being removed from their place in this work because of that. And so there is a need. Well, equity, the opposite of equity is disparities. We don't own any stake in the game when it comes to child welfare, and our children are chattel. So
Thank you.
very well. No
Seeing
questions?
no other questions, thank you for your testimony.
All right.
Next testifier for LR 404. Welcome. You can proceed.
Chairperson, Arch, members of the Health and Human Services Committee. My name is Elizabeth Brown, ELIZABETH, BROWN. I'm an enrolled member of the Omaha Tribe of Nebraska, and I am from the Nkesabeh clan, which is the Buffalo clan. I am also the president of the board of directors of the Nebraska Indian Child Welfare Coalition, NICWIC. NICWIC is a grassroots collective of tribal and other partners dedicated to the full enforcement of and compliance with the federal and Nebraska Indian Child Welfare Acts. We strive to protect Native children from being unjustly removed from their families, tribal communities, culture, and heritage. Thank you for the opportunity to testify today on LR 404. The disproportionality rate of Native American children in the child welfare system nationally and especially in Nebraska is significant. Native American children comprise of only 1% in Nebraska population, but represent 3.9% in the children in the child welfare system. This is almost 4 times greater than the percentage in the state population. That makes Nebraska the 4th most disproportionate state for Native American children in this country. Historically, the U.S. government has inflicted egregious harms and abuses on Native children through family separation by the boarding schools and the Indian Adoption Project. This continues today through state child welfare interventions according to the disproportionate numbers of the Native children in the Nebraska child welfare system. In 1978, Congress passed the Indian Child Welfare Act to seek to remedy some of those harms to preserve the security of Indian tribes and families. However, the federal ICWA is not well understood or enforced and is under threat by a case heard by the U.S. Supreme Court last month, challenging its constitutionality. Therefore, state action and protection is needed now more than ever. Thankfully, Nebraska Legislature passed LB 566 unanimously in 2015 to provide clarity to state agencies and courts regarding the provision of ICWA. We need to ensure these strengthened provisions remain in place and are consistently implemented to protect Native American children and families in Nebraska. We recommend several measures we believe would help to improve the system. First, tribal partners need to be at the table. Too often, tribes are left out of decisions and aren't considered when statutes are enacted or amended. If we consult with tribes prior to enactment of state statute amendments, we can prevent unintended consequences. Second, the option of customary adoption should be allowed in Nebraska. This is a practice of transferring custody to adoptive parents through tribal court without terminating parental rights, which is more culturally appropriate and exists in other states. Current Nebraska state statute requires termination of parental rights to finalize an adoption, which prevents an adoption subsidy through Nebraska DHHS to the adoptive family. Finally, NCWIC provides numerous trainings across the state currently and is open to providing more educational opportunities to juvenile court stakeholders. We know additional culture competency and cultural responsiveness trainings are needed. These are only a few suggestions. Culture is a protective factor, not just for Native American children and families, but for all families. Much more needs to be done to preserve culture and to protect families, and we hope to participate in future conversations and efforts. Thank you, Senator McKinney and the committee for examining this important issue, and we urge the committee will take meaningful action on this in the upcoming legislative session.
Thank you. Are there any questions? Seeing none, thank you for your testimony. Next testifier for LR 404.
Hi, my name is Grace Johnson, GRACEJOHNSON. I am a mental health therapist and a drug and alcohol counselor. I have worked on child welfare cases. I've worked as a family support worker prior to getting my master's as a therapist. And after achieving my master's, I had started working on ICWA cases, which you had heard about previously. And so I live in Omaha, Nebraska, but most of my cases were involving Native American children in the welfare system, our CPS system. I had to, during my time with these cases, I had to become an advocate because many times the children and the families didn't have the advocates. Now, this is something that's very dear. I'm an enrolled member in the Oglala Lakota Sioux tribe. And having to testify and work with these children and these families in the system has brought to light to me to seeing a lot of the issues that you see with families that enter into the system. These children and these families tend to have a lot of trauma. They don't enter into the system because their families are healthy, right? They don't enter in because their family's functioning correctly. People talked earlier and they gave a lot of testimony about what brought people into the system. And I always bring this up as intergenerational trauma is real, it's there. And this is what we see many of the families entering into is because of addiction, intergenerational trauma. Now, if we're not addressing the underlying cause of this, if we're not looking at this matter as a real thing, we're just putting a Band-Aid on the situation. We're not necessarily doing any real work. You're just going to continue to be putting out fires. You're going to continue to be just putting a Band-Aid on it. There's no real solution here if we're not addressing that. There has been a push in the state for trauma-informed care, but I think it needs to be advocated for more. I think there needs to be more work on this. There needs to be more training on this. I really do believe there is a need for intergenerational trauma or just trauma work and addressing addiction. When I worked with the families, I had to work with the parents too, correct? I really advocate for more family therapy, advocate for more education on what is attachment when children are born, parental skills. There's a whole list of things here that we're not addressed and we're not talking about. Unfortunately, we have a shortage of therapists in the state. They're rural and urban. So we are working in a situation where we just don't have enough qualified people, really. But working on intergenerational trauma, I have found to help a lot of the parents understand where they ended up in the system and how they got here. Because sometimes they're just completely confused on it happened and they don't know how it happened, even though they were participating in it. And it becomes like a David and Goliath situation where the parents don't feel they have the support, the understanding, and they don't necessarily have those that are supporting them. I had said I worked as a family support worker and I had a bird's eye view of the whole system. I was the one who took the kids to the family for the visitation, right? The system is broken and I can't blame anybody. It's just that the workers are overwhelmed. There's not enough funding and support. It's a huge, complex problem that there's multiple layers that need to be addressed. But I would say addressing intergenerational trauma is one of the underlying causes you're definitely gonna have to work at and look at. Do you have any questions?
Any questions? Senator Williams.
Thank you, Senator Arch, and thank you, Ms. Johnson, for being here. And I just want to expand on your testimony that you talk and your work is mostly with Native American children, and you're talking about intergenerational and addictive issues. In your judgment, would those same issues be there for the other minority populations that we're talking about today, the Black population, the Latinx population?
Absolutely.
Thank you.
Other questions? Seeing none, thank you for your testimony. Next testifier for LR 404. Do you happen to have a green sheet?
I did not fill one out
Okay.
because I wasn't planning on testifying.
Sure.
I'm just listening, but I'll fill it out on my way
Yeah,
out.
she'll get you a blank, but please do fill that out and
Okay,
provide that.
thank you, Senator Arch. And members of the committee, I'd like to thank Senator McKinney for introducing this interim study. As I said, I am Judy Goshkabosh, JudiGiashkibos. I am the Executive Director of the Nebraska Commission on Indian Affairs, and I am a member of the Ponca tribe, and I am also Santee Sioux. And I decided to come to the hearing and listen, and I want to thank all the fabulous testifiers that preceded me. At first, I didn't know that there was going to be any Native voices here, so I was really getting nervous, but I thought the African American community did an outstanding job of presenting their case about this terrible state of affairs for our people with DHHS and what's happening in our state concerning our children. Myself, I would just like to say historically, I am a survivor descendant of the Indian boarding schools. My mother and two of my aunties went to the Genoa Indian School, where the motto was, kill the Indian, save the man. And as you've been reading in the papers, we are right now in search of finding 86 children that are buried over at Genoa, Nebraska. That was a part of our nation's history that isn't talked about. It's pretty invisible. People don't know that this is what was done. And that brings us up to where we are today and informs how our people are treated, why we have missing and murdered Indigenous women, because we are invisible people. We are throwaway people. And so we have a lot of things happening. Poverty is probably the underlying, there's causational reasons why we're in the system and our children are so vulnerable. I want to give you an example of a case that just came to our agency last week, right before Thanksgiving, to demonstrate this broken system that we're dealing with. I had a call from one of our providers here in the state. I'm not going to say the name of the organization, a very well-known, highly respected caretaker of children. This entity had received a child that was getting ready to age out of the state system through the Bridge to Independence. Okay, so the child was sent over to their care for 5 days, as that is provided for, and it was timed for the child to be sent to an apartment, independent living. This young woman was a Santee Sioux tribal member, and she was getting ready to age out. She had been trafficked. She had no car, no education, no resources, but she's living at this nonprofit for 5 days. And they called me because the person who's the director knows me, and they wanted resources. What could they do to help this young Native girl from the Santee Sioux Nation who was in their care? So I gave them a lot of resources: Society of Care, legal aid, the Santee Sioux Nation, on and on. And then I was told that this young girl was going to then be put in an apartment after the 5 days were up. So I followed up on this with the director, and he said, here's her caseworker. She's now in an apartment, and she's in a hotel room. She's in a hotel room, and we no longer have her. She's been put in a hotel room, and she's going to go to an apartment. Well, I think that young lady is really at risk to what is going to happen to that young Santee Sioux Nation girl who is now aged out of the system. That is a failed system. And I just shudder to think what will happen to that young girl. So I'm giving you an example of something is broken and it needs to be fixed. And how can we work on that this next section to help all of our children be treated better? And for all of what you've heard all the reasons why our children are treated differently, including our hair. You know, the Black children's hair, that a common right to be treated with dignity is denied those little children. And the ignorance and the lack of training to the caseworkers is just a shame that they aren't utilizing us and having us give more training. That's what our agency's there to do, and that's what I'm committed to do. So I just felt like I wanted to say that, and I think Grace did a great job in the NICWIC. They're doing great work, and there are many other nonprofits that are doing great work, but we need the state to help us, and we need you all to make sure that the right things are done and that this can't continue to happen. Do you think that's a good scenario of that young girl? That was right before Thanksgiving, and I went home and I'm like, oh my gosh, something's really wrong with this world.
Well, thank you for your testimony. Are there any questions? Senator Williams?
Thank you, Chairman Arch, and Judy, thank you for being here, and thank you for your advocacy. I think when many of us hear you use the term forgotten and throwaways, that touches a real nerve and makes us all feel like we need to be forgiven for something. My question is, there's been a great deal of discussion, in particular over the last year to 18 months, concerning something I brought up earlier, institutional racism, but it's primarily that discussion is dealing with the Black Americans in our country. Would you say that same kind of institutional racism exists for Native Americans?
Absolutely.
Can you expand on that?
Without a doubt. Well, I'll just use myself as an example. I had one of 10 children, lived in a 3-room house until I was 10 years old with 13 people, had an outhouse. We had caseworkers come to my home quite often, and I was the child that was designated, because I was pretty precocious and articulate, to convince the caseworker that they shouldn't take us out of the care of my parents, who were doing the best they could. And I didn't know that we were poor. My grandmother, I slept in a rollaway bed with my grandmother and little sister in the kitchen. And I went to school, and I loved school until I went to a friend's house, and her father was a dentist in Norfolk, Nebraska. And she had 2 beds in her bedroom, and no one slept in one of those beds. I was like, wow. Then I thought, my life's really different. But that didn't mean my life was less than hers. But I was blessed by my grandmother, my Santee Sioux grandmother, who told me stories and knew her language and culture. My friend didn't even know her grandmother. So the caseworkers, they look at us as pitiful. They don't understand our history, that we are dual citizens. You know, definitely there's a bias against people of color. And also during pre-ICWA, Indian children are beautiful little children, and they wanted our children, and they thought they needed to continue to try to assimilate us and make us be cookie cutter Americans, and that we would be better with a white family. But we wouldn't have my grandmother telling me those stories.
In your judgment, as a person who has dealt with this from the day you were born, why are so many people afraid today to talk about openly and discuss the issue of institutional racism?
I think it's, you talk about intergenerational trauma. I think it's ancestral guilt, and it's a real dark stain on America's history. And it's hard and also you haven't learned about us in history, so you don't really know the facts of all of this. It's just painful for people of color to own this and to say it, as well as it's painful for us to have to sit here and tell you about it. And believe us, we live this, we know this. So I think you have to stop and say, it's time to own this and say, this really did happen in America. It didn't just happen in Germany, but this is on our land here. For Native people, we have nowhere to go. You know, we can't go back to learn our languages over in Europe. So America was really built on the backs of slaves and Black people, and our first people's lands were stolen, and that's why we had the boarding schools. It was cheaper than having wars. Every battle with Native tribes was $1 million, and the government said, we have to stop having wars. So how we do it is we kill our children. My mother and her sisters, they were the last soldiers in America that fought the wars, that freed the land so that everyone could have this beautiful country of America. And we all still want to live here with you. We love our Mother Earth, but we want to find a way that our children can still be who they are and not have to be an assimilated cookie cutter American, but can be a proud, Ushne-Ponca or whatever your tribe is. And we go to fight in the wars. Our Native warriors fight at a higher rate than anyone. So it isn't as though we're not proud of this country. So I hope, Senator, that kind of it's painful. It hurts. There's been so many bad things that have happened in the last few years with COVID and all. We don't want to feel sad. We have inflation. People don't want to learn all these things and say, let's just move on. You were conquered people. It's time to get over it. But we don't think so,
Thank you.
Senator Merman?
Yeah, and thank you for your testimony. And you'll have to forgive me for my ignorance, but you talked about the Genoa boarding school and the past history of how Native Americans were treated and so forth. I suspect that, and you'll have to correct me if I'm wrong, but the traditional family wasn't always the way that different tribes operated or had traditional families like we think of a mother and father and children.
I think
Is
that
it
would be
different?
true. It's not a core family of a mom and dad, 2 children, a garage, everybody gets a bathroom and a bedroom. No, you did whatever you had to do. And, you know, the Teoshpe, the extended family, we managed. And if there were relatives that needed a place, they were a part of our home, and we opened our home to that. So that's kind of that tribal communal way of looking at living that the dominant world, the non-tribal world doesn't relate to. So that's, I think, why then the people that are deciding what happens to these children say that home's not fit. That's not a good place for those kids to be. But I wouldn't trade my life and my experience as a poor child living in that little house for anything, because I have so many great memories, you know, but I don't know. I'm sure it was nice to live the other way too, but that's just the way it was.
Well, I'm thinking about back in like the late 1800s and early 1900s when the boarding school was really, I think, going at its strongest. And, you know, when this part of the country was first being, for lack of a better term, civilized, I guess. Probably not the best term, sorry about that. But there were differences, I think, with the family structure, quite often, like you said, more communal. And how does that still have an effect on the family and social services today?
Okay, so going back to the Genoa Indian School, that was the 4th school opened by General Pratt to kill the Indians, save the man, Carlisle being the first in 1879. There were over 20,000 students that went through that school, and the whole purpose was to separate the children from their families. To destroy a people, that's what you do. You separate families. That's still happening in America today. So you take away their language and their ability to be that tribal person, hoping then that they will, however, not allowing us to have aspirations to go to college and do things, but to be the servant labor for the rest of the world. So we were trained, my mother learned how to be a cook. Originally, they only went to 6th grade, then they finally let them go to high school. But it was never intended that they could go to college and become an attorney like my daughter or a teacher like my daughter. It was always that you could do something here, but stay in your lane, be the conquered people, and be our servants, just like it was for the African American people. We need you. And now we have the Hispanics, and they are doing a lot of that. And who's next? I don't know. But that's our America. And that's why people don't want to talk about it. You know, it's painful. And there's nothing wrong with our family system. That's a good thing. It's a good thing to have lots of aunties and grandmas and people that step in. So when you're at the boarding school, you lost that. You didn't know. You didn't get to see what it was like. You went home and you were traumatized. I compare it to a military. You have PTSD. The men go away to fight in a war. They survive. They see horrible things happen. They go back home. They don't tell their mother, their wife, what they saw. Likewise, people ask me every day, what did your mother tell you about being at the boarding school? Very little. She survived. She didn't want to inflict that pain on me, but I could see it in her. And I am still today healing from that intergenerational trauma. It's an ongoing lifetime thing. So I think that it's really time for the Nebraska Legislature to step up and do something good. And you can. It's time. really it is, with leadership like Senator McKinney, it's time to move forward. And I'm just really proud to be here, and I want to work with you and all the people that testify to do something better. We can do better. We can be better. Nebraska is a good place to live. This is my homeland. I love it. I'm proud to be an Ushne-Ponca Santee Sioux person. We all need to live together in harmony, but for you to be better, I shouldn't have to be less. And our families know how to take care of our own people. And maybe it's not the way you think is best, but we're pretty happy with our traditions and who we are. And some of us have to learn those because those were taken away from us. We are regaining our language that was taken from us. That's a long, hard process.
I agree.
Thank
you.
Thank you for your testimony today. Next testifier for LR 404. Is there anyone else that wishes to testify on LR 404? Senator McKinney, you're welcome to close. We did receive one comment. It's from the Department of Health and Human Services for your information.
Senator Arch, thank you. Thank you to the individuals that came down and took time out their day to come and testify on LR 404. I think it's very important, and I think it's a conversation that we should have more often. But it's a conversation I think we should have often, but also do things after we have that conversation. Senator Williams, you asked whether it was systemic or institutional racism. And I would say yes. And I would say that because currently, and it's nothing against our current CEO of the Department of Health and Human Services, but she is a Black woman. And although that is a fact, we still have disproportionate outcomes for Black, Native American, and Latinx kids. And that points to institutional and systemic racism. Although representation is important and having somebody that looks like you is important, what is also important is making sure that those systems that those individuals are working in are open to change, willing to change, and are, doing things proactively to do those type of changes. And I don't think that's occurring. And I think it needs to start occurring, because until we start to change these systems, we will continue to see these disproportionate outcomes for these families and these kids. That's also, and that goes with diversifying the caseworker workforce and making sure that they're culturally competent and not fresh out of undergrad working for the department and going into a home talking to families that they've never interacted with before in their lives. We also have to make sure that when we do make changes in this body, we look at it through a holistic lens and a racial equity lens. Because, for example, we ended the contract with St. Francis. When we did that, St. Francis, the state took over. And when the state took over, the state began to not refer as many youth in foster care to day reporting services. Why this is important, the youth going to those day reporting services are some youth that are very highly at risk, and that if not supervised or have proper supervision or somewhere to go during the day, they end up in our streets. And if you paid attention to the news in Omaha over the past year, you'll see that we have increased juvenile contact with law enforcement and offenses. And this is partly the reason, which is why I would also advocate for, in the future, racial impact statements, not only for the criminal justice system, but for the child welfare system, because we have to ensure that if we're making changes, we're looking at it holistically in order to decrease any negative impacts that possibly will occur with any type of change. Because it can be a pipeline to prison. If you go to NSP right now or LCC, you walk through there and talk to those men. A lot of those men were in the child welfare system, but because they were failed, as time progressed and they aged out and went into adulthood, they ended up there. And now we have an overcrowding situation, which is why we need to start looking at these things more upstream and getting to the root. Because if we don't get to the root of these issues and keep throwing Band-Aids at them, nothing will ever be solved. The state will continue to waste money on these solutions that aren't working. We can't build our way out this issue. We can't hire a new face out this issue. We have to be intentional and break down these barriers to make sure that these families are properly taken care of and our kids are properly taken care of. A kid shouldn't be suspended from school because they were late to school. That has never made sense to me. When I was in high school, I was suspended before because I was late to school. My mom didn't have a vehicle and the city bus was late a few times. And because of that, I was late. So because I was late, I was suspended. Made no sense to me. If I'm showing up, I'm showing up. I was an athlete. I had decent grades. It wasn't like I was showcasing anything that said like Terrell is late and it's this big problem. But because we don't look at these policies holistically, we say, oh, let's just put a penalty in place and then they'll show up in school on time. That's not the case all the time because life happens. We have to account for life happening and human error. But we also have to be human and treat our kids and our families as humans, no matter where you come from, whether you're a Native American family, a Black family, a white family, an Asian family. We should all be treated properly with equity. And equity is important because although getting treated equally is great, we have to account for the historical traumas that have been in place for years. And like Ms. Gashkabash and stated, this country and these systems weren't created with us in mind. And because of that, we have to go back and look at these systems to make sure they're working and are for everyone and has everybody in mind. And with that, I'll thank you. And if you have any questions, I'm open to them.
Are there any questions? Well, thank you very much for bringing this LR. And with that, we'll close LR 404 and we will move to open LR 408. And I believe that is yours as well, Senator McKinney.
Yeah.
If you could leave the room quietly, I'd appreciate it. We have two more LRs that we need to hear this afternoon. All right, you may proceed.
Thank you, Chairman Arch and members of the Health and Human Services Committee. We are here today to discuss LR 408 to study and examine ways to grow and diversify Nebraska's healthcare workforce. The purpose of this resolution is to propose ways to grow and diversify the workforce by engaging communities that are underrepresented in the current healthcare workforce. The state of Nebraska should focus on developing a healthcare workforce that reflects the communities in our state. Health disparities have long existed for racial and ethnic minority populations, resulting in individuals suffering from suffering disproportionately from treatable, curable, and preventable diseases. A lack of diversity in the healthcare workforce could worsen these healthcare disparities. According to a study from the George Washington University Milken Institute School of Public Health dated in March 2021, Black, Hispanic, and Native American individuals are all significantly underrepresented in the healthcare workforce in the United States. The state of Nebraska must work with healthcare providers and healthcare educators to educate, recruit, retain, and cultivate a diverse healthcare workforce that mirrors the communities they serve. You ask why? Diversity in healthcare helps ensure that all ethnicities, backgrounds, cultures, beliefs, and perspectives are adequately represented, thus providing the best care for everyone. People feel safe around people they can identify with. There's a certain level of comfort that comes with knowing you're in the care of a professional that not only sees you, but understands the nuances that come with being you, and those nuances are being accounted for when caring for you. When patients cannot find providers that resemble them or their facets of life, being misunderstood or not receiving appropriate treatment is likely an end result. Diversifying healthcare makes care more accessible to patients who might otherwise be overlooked. The more diverse, the better they can respectively and knowledgeably assist their patients. Diversifying healthcare makes care more accessible to patients who might otherwise be overlooked. As I stated, the more diverse, the better. Patients who are the same race as their providers report better outcomes and are most likely to be prescribed preventative cares. The Center for Disease Control and Prevention reveals Black and Native women are 2 to 3 times more likely to die of pregnancy complications than white women. There's a plethora of Black women sharing their birth stories and detailing these events of mistreatment, not being believed by doctors and nurses, and not having their symptoms taken seriously, and outright malpractices during their deliveries. Something we also must look at is looking at diversifying the healthcare workforce as a tool to decrease poverty and to lift historically impoverished communities out of poverty, which is one of the biggest drivers of poor healthcare outcomes, educational outcomes, prison overcrowding, overrepresentation in the child welfare system, and the widening of the racial wealth gap. I think this is very important. I think it's something that we should all look at because, I've heard the horror stories throughout my life from family and friends about going to the doctor and having some type of pain or ailment, and the doctors just looking at them like they were crazy and didn't make sense. To only leave and be rushed to the hospital later because the doctor failed to recognize what was going on with those individuals. And why I say it's another tool to work to decrease poverty, I think the healthcare industry, like every other industry in the state, needs to be a part of the solution when it comes to decreasing poverty in our state, especially in communities like mine. And with that, I'll open myself up to any questions and if you have any concerns.
Thank you, Senator McKinney. Are there any questions at this time? Seeing none, we'd invite the first testifier. Mr. Hale's jumping up quick. Welcome.
Thank you. Senator Vice Chairman Williams and members of the HHS Committee. My name is Andy Hale, ANDYHALE, and I am Vice President of Advocacy for the Nebraska Hospital Association. Our nation is made up of people of varied national origins, ages, religious affiliations, languages, genders, disabilities, socioeconomical and occupational statuses, geographical locations, among many other traits. With our country growing more diverse each year, so should our healthcare workforce. Studies have shown that having a diverse healthcare workforce gives healthcare organizations access to more perspectives, improves productivity, enhances organizations' ability to solve complex problems, and more importantly, increases patient satisfactions and outcomes. Patients need to feel comfortable and at ease with their healthcare providers in order to establish good communication and therefore good care. A provider who understands a patient's unique background is in a better position to explain test results or a diagnosis. And a patient who feels their provider represents them is more empowered to ask questions and to be assertive and likelier to follow the provider's advice down the road, leading to a better outcome. The COVID-19 pandemic has exploited these existing health disparities, disproportionately impacting communities of color. Pacific Islanders, Latinos, Indigenous, and Black Americans all have a COVID-19 death rate of double or more than of white and Asian Americans. There is also a workforce component to all of this. You've heard us on many occasions from the healthcare industry really sound the alarm bells on workforce shortages, but there's a segment of the population that is sitting on the sidelines, and those are the legal immigrants. And again, I want to stress legal immigrants. The NHA has been working with the group to come up with permanent solutions for people that are here legally and cannot work. There are around 2,000 temporary protected status recipients, the TPS recipients, and more than 5,000 residents are DACA eligible in Nebraska that cannot work. I do have a few of our members that have made great strides in our programs with not only reaching out and cultivating a workforce, but putting them to work, encouraging them in leadership positions and so forth. And you'll hear those testifiers behind me, as well as those in the education system that have done a great job as well. I'd like to thank Senator McKinney for introducing this LR, and I appreciate him and his staff's work in bringing awareness to this issue. And I'd be happy to answer any questions.
Thank you. Other questions, Senator Walls?
Thanks for coming today. I am glad that you are aware of the need for diversity. Has the hospital administration, are they trying to address that issue, and in what ways, or what are there things that we can do to?
Well, you'll hear from our members that have really focused on this and have programs specifically addressing needs in certain populations. And as far as a specific ask, as of right now, obviously this is just a study, but I think when you look at workforce and how do we make sure that everyone who is able to work can work, and how do we cultivate that workforce, I think that is something that we will have next session in regards to specific asks to workforce in regards to this population and overall workforce issues.
All right, thank you.
Other questions? Seeing none, thank you for your testimony.
Thank you, Senator.
Next testifier for LR 408.
Good afternoon, Senator Arch, members of the Health and Human Services Committee. I am Kenny, Kenny, McMorris, MCMORRIS. I have the pleasure of serving as the Chief Executive Officer for Charles Drew Health Center in Omaha. I'm also here representing the Health Center Association of Nebraska and the 7 federally qualified health centers in our state. Nebraska Health Centers serve an incredibly diverse and complex population. Over 95% of our patients fall below 200% of the federal poverty level, with 70% of them being racial and ethnic minority, and 37% of our patients being uninsured. Last year, Health Center served over 113,000 Nebraskans across 72 service locations within our state, providing primary medical, dental, behavioral health, pharmacy, and wraparound support services regardless of insurance status or ability to pay. Providing high quality, culturally appropriate healthcare is at the heart of the community health center movement. We know that there are significant health disparities in Nebraska, whether they are based on income, race, ethnicity, insurance status, immigration status, employment status, or education and gender. Much of these issues have to do with things that happen outside of our 4 walls within the health centers. However, data shows that implicit bias that healthcare providers hold can exacerbate these issues. For example, as previously mentioned by Senator McKinney, Black mothers in the United States are more than 3 times as likely to die during and after childbirth as white mothers, and more likely to die than Black mothers in any other developed country in the world. Hispanic, African American, and Native American Nebraskans are significantly more likely to report worse treatment when seeking healthcare than those of other races. Developing and sustaining a diverse workforce is critical to breaking down systemic barriers to equitable care. We recognize that workforce shortages exist across our state. We feel those shortages in our own health centers every day. We also look for innovative solutions to these critical workforce issues to improve that we build systems to recruit, train, support a diverse workforce that is representative of the patients in which we serve. Based on the most recent Nebraska healthcare workforce study, while there have been most modest increases in the number of female physicians, the race and ethnicity distribution of physicians has remained relatively unchanged since 2017. There's a similar trend in dentists, physician assistants, and pharmacists. And based on data from the Behavioral Health Education Center, only 1% of behavioral health providers in Nebraska are Black. In order to adequately understand cultural perceptions about accessing healthcare services and addressing centuries of systemic barriers that lead to distrust, we must build a workforce that is representative of all patients, expanding training opportunities that afford individuals the ability to learn where they will live and where they will practice, develop pathway programs promoting mentorships for students, and expanding financial support through scholarships and loan repayments are all ways to increase the workforce in our healthcare community. We cannot begin to improve healthcare access in Nebraska without having a workforce that is representative of the communities in which we serve. We are committed to working with all of our partners in healthcare, the legislature, the administration, to develop innovative solutions to address this workforce crisis. I want to give a special thank you to Senator McKinney for raising this and introducing LR 408, and the committee for taking time to listen to what we have to say. I'll answer any questions that you may have.
Thank you. Are there any questions from the committee? Senator Williams?
Thank you, Chairman Arch, and thank you, Mr. McMorris, for being here. This committee and this legislature this past year tried to step up and address one particular piece of this issue in workforce, and that's the nursing shortage that we have in our state. We have more nurses retiring in our state than we have seats in all of the nursing schools put together. What we found out in some of the testimony, though, is that we have certain nurses schools that have many more applicants to them than they can take in, and yet we have vacant seats in some of our other nurse training schools. You can lead the horse to water, but you can't make him drink. How do we make that connection with the minority population that we're talking about today, that there are these opportunities available for them? And now we created some scholarship dollars for that through legislation that we just passed this past session. How do we connect those dots?
Yeah, great question, Senator Williams.
It's a long question.
Yeah, no, it's a great question. We spend our time at Charles G. Health Center trying to solve this on a pretty regular basis. It starts with creating a pipeline at an early age. We know our kids in our communities and our schools that are talented, that have an interest in the healthcare profession. And we have to be intentional about providing those opportunities in a real and meaningful way to those young people. Exposing them to careers in healthcare, I think this does address, and you make a great point, Senator McKinney, some of the economic challenges that we talk about in terms of improving the quality of life and lifting people out of poverty. Our academic institutions do a decent job of being intentional about recruiting within, and I'm going to speak specifically about North and South Omaha, but we can do better, and we have to do better. We know it's pretty clear that you increase the likelihood of being able to retain individuals if they are from the communities in which they are serving and the state in which they are living. There's a level of commitment there. And I believe if our state is truly interested in addressing brain drain, we are going to start and be very intentional about working with our public school systems and school systems to be able to address and make sure that we are training and cultivating a culture of learning within the healthcare fields. I think the earlier that you start, the better off you will be, and you will cast a net wide enough to really take that spark that's there for many of our babies and blow it into a flame. So it really starts early. I think the other part is really looking at how do we address a lot of the institutional and systemic problems that we have in our systems. A lot of our families are waking up every day trying to make the impossible possible. Life has challenges. How do we create an environment that uplifts them and supports them to help them reach their ultimate goals? This could happen across all industries. specifically I'm thinking about healthcare, but you can say in housing, you can say education, employment, entrepreneurship. So this is really about a process and being very intentional at an early age, addressing the issues that have been generational. These are generational problems that we're facing. It's not going to be a one size fit all, but it really starts with making sure that we're investing in our kids and supporting the families, whatever that family structure may be. Along with the question on that.
Any other questions? Seeing none, thank you very much for your testimony. Next testifier for LR 408. Good afternoon.
Good afternoon, Chairman Arch and members of the Health and Human Services Committee. My name is Tierra Robinson, TIERRAROBINSON. I'm the Director of Adaptive Learning and Inclusive Excellence in our Office of Inclusion and Diversity at Nebraska Medicine, which is a nonprofit integrated healthcare system affiliated with the University of Nebraska Medical Center. Our health network includes 2 hospitals, Nebraska Medical Center and Bellevue Medical Center, and nearly 70 specialty and primary healthcare centers in Omaha area and beyond. I want to start by expressing my gratitude to Senator Terrell McKinney for introducing LR 408 and giving us an opportunity to have this important conversation today. At Nebraska Medicine, we are committed to building a strong, resilient, and diverse workforce. As an inclusion and diversity department, we are placing a greater emphasis and awareness on the multi-dimensional layers of diversity throughout our organization. We have made it a priority to focus on strategies that will allow us to advance health equity, reduce disparities in healthcare, and address biases. This is important because when we are intentional about our efforts that support marginalized populations, we lift everyone up. It is important to our patients that we have a workforce of individuals that look like them, caring for them. It increases their trust in us as a healthcare system. COVID has impacted our workforce tremendously, and therefore it is critical that we not only focus on recruiting a much needed diverse workforce, but also supporting our currently existing workforce. This has included proactive approaches of establishing diverse employee health resource groups, developing career pathway programs, and engaging in community partnerships. Our employee resource groups, or known as ERGs, affirm and empower the multiple and often intersecting identities of our workforce. Our ERGs include an Emerging Professionals Program, LGBTQ+ Employee Alliance, African American and Black Alliance, Latin Excellence, Asian American and Pacific Islanders, Administrative Professionals Network, All Abilities and Disabilities Partnering Together, Nursing Wise, and RISE, Respect, Inspire, Support, and Empower Women's Group. Through our work through these ERGs, we are able to offer culturally relevant and affirming programming throughout the calendar year. In March of this year, we launched the Health Equity, Diversity, and Inclusion Council, known as our HEDI Council. This is a cross-functional council that works collaboratively to champion, advance, and support the work identifying gaps in access to care and examining the culture and climate of our workforce. Members of the HEDI Council and 2 HEDI Council committees include a diverse range of Nebraska Medicine and UNMC clinical and operational leaders, subject matter experts, and community partners. Through the council, we have prioritized the greatest needs for recruiting and retaining a diverse workforce. In July of this year, we completed a comprehensive environmental scan that highlights our growth opportunities within the healthcare system. Through the work of 2 system-wide committees, we are addressing issues related to patient and family experience, workplace culture and community engagement in the context of equity-based care and practices. In addition, we are working to ensure that our healthcare system is accessible for all patients, families, and employees requiring accommodations. Through our recently established Accessibility Committee, we have had an opportunity to partner with the Nebraska Commission for the Deaf and Hard of Hearing to identify strategies to ensure that we can provide the highest level of care to this particular patient population. This includes culturally competent care training to approximately 150 Nebraska medicine leaders and colleagues. There are various barriers and challenges that we face as a healthcare system while attempting to increase our efforts. More specifically, with the increase in the reliance on our contract labor, we have experienced significant budget challenges. We recognize that a significant challenge is that these changes don't happen overnight and will require a long-term commitment to systemic and meaningful change with intentional effort. We look forward to partnering with the legislator in this important priority, and below we've highlighted a few opportunities for the legislator to support this work. One, providing continued support for inclusive and differentiated strategies in higher education. Two, supporting broader loan repayment and expanded student loan forgiveness for healthcare workers and providers. And three, supporting early investments in healthcare certification programs and the development of career pathway programs. Thank you for your considerations, and I'd be happy to answer any questions.
Thank you. Are there any questions? Seeing none. Oh, Senator Mervin.
Thank you. I agree with you that we should have a goal of more inclusive medical providers, doctors, and so forth. But if I'm going to have brain surgery or heart surgery, I don't care what color the person is, or I don't care for any, actually, whatever I'm doing, but it's the most important thing is that they're skilled in what they're doing and their knowledge and, you know, their academia all through the process. So how do you balance that with trying to, you know, fulfill a quote, for lack of a better word, fulfill a quota or check boxes for different types of diversity?
I absolutely agree that the skill set of the healthcare professional is at utmost importance. I'd say the balance is, when we think about from a workforce perspective, is making sure that brain surgeon who's going to operate on you is happy with their employer, happy feeling like they belong to an organization where they can be their authentic self and that they can be in the right mind, body, and spirit to be able to perform the job that they are tasked to do. And we know that when you're able to function in that capacity, that's what allows you to be successful as a provider. And then back to thinking about the person that you are operating on, it matters to that person because representation matters. And as Senator McKinney mentioned, when patients have a provider that they can relate with and that looks like them, it causes for better outcomes in patient care.
I totally agree with you, but I still think the skill and the academics of the provider is the most important thing, above culture or checking boxes on, you know, color or whatever. That skill is the most important thing, and the knowledge of the provider. But thank you.
Thank you. Are there any other questions? Seeing none, thank you very much for your testimony. Next testifier, please.
Good afternoon, everyone. Dear Chairman of Art and members of the Health and Human Services Committee, it's a great pleasure to be here with you today and to speak on behalf of a topic that's near and dear to my heart: creating healthcare career ladders for individuals like myself with underrepresented backgrounds. My name is Selena Espinosa. Selena spelled S-E-L-E-N-E, Espinosa, E-S-P-I-N-O-Z-A. I want to give you a short personal testimony in regards to why this work is very important for myself. I also want to testify to when systems work together, the positive outcome that we can have in our communities. I am a proud immigrant daughter of a family, a mother, single mother that came to the United States when I was 2 years old. My mother migrated here legally with a working visa for Conagra. She worked here for about 11 years, received her residency and her citizenship, and I became an American citizen under her citizenship. I met here with my mother after almost 11 years of not seeing her, and moved to this beautiful country. I did not speak the language. I didn't know my siblings and my father. And I could tell you, at least it was a very challenging moment as a teenage young female to move to a country and to a family that I had no familiarity with. But coming from my grandparents' household, education was the number one priority that I would keep in mind and in heart, that was the dream. That was the possibility here in America to come and get an education. Coming here, I moved to South Omaha, and I became a member of a future medical scholars in high school. Again, not speaking the language, but having a dream that I would get into the medical workforce. The most important and that made my story a success I could consider was the support from my educational system to my employer system. I went from high school to Methodist College and received a surgical assistant degree. I have currently worked in surgery for 21 years. And I am proud to say that really made the difference. The educational system supporting us with financially with scholarships, and then my employer also supporting us with the diversity and the needs that I needed as coming in as a foreign to the country. And after 21 years of my practice, I continue to see the lack of diversity in healthcare workforce. That's why I took, as a personal challenge to go back to my community and create this beautiful program that I'll speak to you about. And this could not have been done without the support of CHI Health. CHI Health has engaged in vast growing number of partnerships, initially growth and diversity workforce. We actively partner with Omaha, Ralston, Papillion, and La Vista schools and Grand Island schools. In fact, CHI Creighton University in Bergen, 2-year medical academy model where we look at students to complete a CNA certification. We also engage our students in clinical rotations to recognize the best practice by the Nebraska Health Department in Education and the Health Science Careers and Technical Education Standards. For the purpose of today's speaking on behalf of diversifying our workforce, I will speak to you on our program, Siembra Salud Health and Diversity Program. This program addresses 2 distinct workforce challenges that our healthcare system is now facing. One, we know that there is a deficit of skilled workers to meet current and future demands of healthcare services, and also the lack of racial, ethnic, and cultural diversity. Our program focuses primarily on our Latino and refugee communities, and approximately 11% of our Omaha Metro residents identify as Hispanic or Latinos. I recently, in our community assessment, the data demonstrated that there is a large burden in chronic disease and social risk factors in those communities. Poor health, unemployment, poverty, unstable housing, and food insecurities within the Hispanic and Latino communities, or also the non-Hispanic white residents. Our program works on 3 levels. We work, 1, to increase the number of youth exposed to healthcare sector careers. We provide students with exposure to a broad array of high demands in careers and clinical tours. 2, we increase youth career readiness. We made a partnership with Latino Center of the Midlands, where we bring our students to gain experience in healthcare careers. And 3, we increase the number of Latino and refugee employed within our healthcare systems. I want to thank the Health Human Services Committee for listening to us and understanding that this is really, truly a critical moment in our healthcare field. So we do support diversity workforce, and also want to thank Senator McKinney for this introduction, that it is a very important resolution. I would be pleased to answer any questions you might have.
Thank you. Are there any questions? Seeing none, thank you very much for your
Thank you.
testimony. Next testifier, please, for LR 408.
Good afternoon, Chairman Arch, members of the Health and Human Services Committee. For the record, my name is Nicole Carrott, NICOLE-CARRITT, and I serve as the Assistant Vice Chancellor for Health Workforce, Education Relations, and the Director of Rural Health Initiatives at the University of Nebraska Medical Center. I am appearing today on behalf of the University of Nebraska system to address LR 408. I want to thank Senator McKinney for bringing this important issue to the committee. UNMC has long been committed to educating and preparing the state's health workforce to ensure students are well prepared to meet the unique healthcare needs of rural and urban areas of Nebraska and beyond. Through longstanding programs such as immersive high school programs, guaranteed admission pathway programs for rural and urban underserved residents, and interprofessional student interest groups, UNMC is helping diversify the healthcare workforce that will improve access to quality healthcare in communities across Nebraska. While not an all-inclusive list, I'd like to highlight some pathway programs with those aims. The UNMC High School Alliance is an immersive experience in the health science professions. More than 70 junior and senior level high school students from more than 25 participating high school districts in the Omaha metro area get to learn from experts and practice hands-on skills each year. The program is an inside look at what it's like to be a healthcare provider and researcher. Courses cover various healthcare topics such as infectious disease, anatomy, and medical decision-making, taught by UNMC faculty on our Omaha campus. Students use their experience in the UNMC High School Alliance to set themselves apart on college applications or as a springboard to participate in STEM enrichment programs at UNMC. Multiple students have been accepted into the Urban Health Opportunities or UHOP program, where they'll study pre-medicine at UNO with a reserved spot to matriculate to UNMC to the College of Medicine after that. The Rural Health Opportunities Program, RHOP, Kearney Health Opportunities Program, KHOP, and Urban Health Opportunities Program, UHOP, are decades-long model programs designed to address the healthcare needs of rural and underserved urban areas of Nebraska in more than 10 healthcare disciplines. The Health Professions Pathway programs recruit, educate, and graduate leaders from Nebraska who are committed to returning to Nebraska's communities to practice healthcare and be critical links to community vitality and strong local economies. The Summer Health Professions Education Program, or SHPEP, aims to strengthen the academic proficiency and career development of students underrepresented in the health professions and prepare them for a successful application and matriculation into health profession schools. The Robert Wood Johnson Foundation funds this program. The 6-week summer program provides scholars interested in medicine, dentistry, nursing, and pharmacy academic enrichment in the basic sciences of math, clinical experiences, career development activities, learning and study skills seminars, and even financial planning. With a sharp focus on enhancing Nebraska's workforce, colleges and programs within UNMC are regularly seeking and pursuing new programmatic opportunities to support career expansion or career ladders, as has been previously mentioned, and pursuing grants and other funding to support new and enhanced programs and partnerships. Diversifying the workforce is a long-term endeavor that cannot be accomplished in a couple of years. It's a long-term and non-ending commitment. We can't simply wait for individuals to seek healthcare careers, but must develop robust pipelines from underrepresented communities into the health professions, beginning in primary education and supported by intrusive advising, mentoring, and role modeling. As you've heard in the comments today, UNMC has developed successful pathway programs in collaboration with multiple partners across the state and nation. However, gaps have emerged over the last 5 years that hinder the ability to build those robust pipelines, particularly the diversity of such. Statewide programs focusing on early exposure to the health professions, from primary education through middle school, are rare. While the federally funded statewide area health education, or AHEC program, previously provided early exposure programs through its 5 regional centers, federal funding requirements have changed the program's focus to those students already enrolled in a health profession training program. Meanwhile, programs for high school students like Nebraska HOSA, Future Health Professionals, exist. and the number of chapters set up by participating high schools in collaboration with the Nebraska Department of Ed across the state is growing. UNMC has hosted the statewide HOSA conference several times and frequently supports these students' engagement. As it relates to pre-health and health professions training programs, students and their families, particularly those from underrepresented communities, must see a pathway into the health professions as a viable option, whether into a certificate program or application to a post-secondary institution. Without earlier exposure to the health professions and intentionally developed and supported strategies and opportunities, the gap is likely to remain or even widen. As a state, we know we're not reaching our full potential to meet the increasing demand for a robust and diverse healthcare workforce. And the University of Nebraska system and all of our campuses are dedicated to being a partner in the solution. Thank you for your time and hearing our comments, and I'd be happy to answer any comments, questions you might have.
Thank you, Ms. Carey. Are there questions? I have a few.
All right, we'll take them.
Really interested in your high school alliance program. And my question is, with the expansion of the medical facilities at UNK with UNMC as the partner, is there any hope of being able to do some kind of high school program like that in the rural parts of our state?
That's a great question. The High School Alliance has actually looked at with multiple rural communities in the central Nebraska area about an opportunity to model the High School Alliance in the Omaha area to a more rural community. And there have been discussions about whether that could be expanded to include what's happening on the Kearney campus as well.
That would be very helpful for the healthcare shortage in our rural areas, as we heard from an earlier testifier. Young people tend to stay close to the area where they're educated and they want to go there. So that. Second question, and I think you heard me point out the issue, one of the issues that I have with nursing schools is that some of them are full and have many applicants and some of them are not. Are there discussions about finding ways to expand the seats available in UNMC's nursing schools?
Well, we're looking across all of our campuses, and part of that goes back to some of the earlier discussion, I think, about just in that early exposure of the nursing professions to some of our more underrepresented communities across the state. And when we do have open seats, are there opportunities to recruit from those communities? Some of it's a cultural issue, so thinking about it's that longer term, earlier pipeline kind of work. But the UNMC College of Nursing is actually looking at some new and expanded ways, particularly on the Kearney campus, to expedite admissions, twice per year admissions, those kind of things, to make sure that we're keeping up again with the nursing shortage.
Just one more question along that lines, and I've talked to Dr. Sebastian many times about this, and you know that. For instance, the UNMC Nurses School that is on the UNL campus,
Yes.
several blocks straight north of us here, has approximately, round number, 600 to 700 applicants for 80 spots. And so they have to be very selective, and there are many applicants that certainly would be qualified that get turned away.
Mm-hmm.
I'm still mystified then that we have open seats other places, but I keep asking the question, as a business person, I would look at that as a significant opportunity. The university is always looking at ways at increasing enrollment, increasing the tuition dollars coming in and meeting these kind of needs. And yet there seem to be stumbling blocks to take that number from 80 seats in a freshman class, or not a freshman class, but the first year in the nursing school, to 100 or 120. And yet, to me, when I hear what the reasons are for not being able to do that, I look at that and say, that's solvable. So I would just plant that as a seed, because I think that's part of our solution too. We've got to expand that number, because even if, as you heard and know, if we put a button every seat, we still are not meeting the needs of those graduating or retiring, excuse me. Thank you. Any other questions?
All right,
Did you want to make I'm sorry, I made a statement there. Would you like to respond?
No, I'm just saying, I absolutely agree. Thank you.
Thank you for
Thank
your
you.
testimony. Invite the next testifier for LR 408. Are there any more testifiers for LR 408? If not, Senator McKinney, you're welcome to come up and close. And while you're doing that, we have some online comments that have come in that will be listed from a Michelle Plogger and a Nicole Barrett.
Thank you, Senator Williams and members of the Health and Human Services Committee. And thank you to everyone that came and testified today as well, taking time out your day on this Friday to speak about this important issue. It's really appreciated. And the conversation kind of went how I thought it should have went. You know, conversation about how do we cultivate this workforce? How do we do it? What are we not doing? How do we connect the dots? I think that's something that we should really look into because like you just said, I think it's a solvable issue to increase the diversity in the workforce. We just got to hone in on how do we solve this issue. And like Mr. McMorris said, we have to create a pipeline early in our educational systems, whether it's in Omaha or in Kearney. We should be finding ways to work with our schools and our school districts to start, starting a pipeline. And one trend that I think might be helpful is when you look across industries, a lot of industries are not necessarily requiring that you have a 4-year degree. So maybe looking at those entry-level positions or those certificate programs or 2-year programs may be a way to start getting people inside the healthcare field. Because what I've noticed from family that have went into the healthcare field, once they become a CNA, 6 months later, it's like, hey, I want to become a medication aide. Then after their medication aide, they want to move up to something else. So I think when an individual is passionate and they see a real pathway for advancement, I think they'll be motivated enough to keep growing. But we have to find pathways and entry points to get them into it and then allow them to grow, but cultivate an environment and a system where they feel free to grow and they see it as a viable opportunity to help, grow our healthcare system, but also help them and their families as far as making sure they have livable wages and things like that. Senator Merman, you mentioned skill set versus just checking a box. I would say, I would hope whoever is doing a heart procedure is qualified to give a heart procedure. But what I also would say is most people that I know, especially from the Black community, we are told early and we are conscious of it that we know that just being Black and just getting an education in whatever industry, and let's use healthcare as for an example, because of systemic issues, we have to be twice as good. I would make a strong argument that if you ended up with a Black doctor and you're on you're on the table for a heart procedure, that individual skill set is just as good as his white counterpart. And so, yeah, you just don't want to throw people into anything. But I would say that if we are able to diversify our healthcare workforce, I would feel comfortable no matter who that person was doing that procedure, because I think we also have to trust our medical schools as well, that they are graduated individuals that are fully qualified and have the skills to perform whatever procedure, no matter where they come from. And with that, I'll open myself up to any questions that you might have.
Are there any questions for Senator McKinney? Seeing none, thank you, Senator McKinney, and that will close LR 408.
Thank you.
Anybody here need a quick break?
Already did it.
We'll go forward then, and open our hearing on LR 367 and welcome Senator DeBoer.
Thank you,
The
Senator.
last scheduled LR and the last scheduled hearing for this committee this year. You have it.
I know, and I'm thinking this may be the last time for your senatorial career this time around.
I hope so.
Okay. Well, thank you, Senator Williams and members of the HHS committee. My name is Wendy DeBoer, WENDY-DEBOER, and today I'm here to discuss LR 367, an interim study to examine home visiting in the state of Nebraska. The first item that I'm going to pass out to you is a map. And this shows, it's a map of Nebraska. It shows where home visiting is currently occurring in Nebraska. Home visiting is an evidence-based service that supports the health and well-being of families with young children. It is voluntary, free for families, and cost-effective. Home visiting programs pair young families with trained professionals who tailor services to meet the family's specific needs. These trained professionals can be nurses, social workers, peers, or more. And they work to form trusting relationships with families to help them reach their goals in child development, family health, parent-child relationships, school readiness, and more. Outcomes associated with home visiting participants include that they are more likely to be enrolled in school and more likely to be employed, are more likely to access prenatal care, have fewer CPS reports to the hotline, are less likely to need emergency medical care, are more likely to start breastfeeding and to breastfeed longer, engage in more positive parenting techniques such as reading time between parents and children compared with families that are not enrolled in home visiting. Outcomes associated with children enrolled in home visiting programs include that they have improved early language and cognitive development, have greater math and reading achievement in elementary school, and have reduced absentee rates and suspensions compared with children not enrolled in home visiting. Here's what can be sort of confusing about home visiting. There are 26 different evidence-based models of home visiting in use across the country, with only a handful of them being implemented in Nebraska. Each model varies in the professional requirements of the home visitor, the length of service, the type of curriculum utilized, and eligibility requirements. The goal is to connect a family with the best and most appropriate model to meet their needs. For example, if you are a new mother coming home from the hospital with your baby, the Durham Family Connects model may fit your needs best because it connects you with a nurse who conducts home visits with you focused on the health of you and your baby. Or if you are a family who is at risk for involvement in the child welfare system, the Healthy Families America program might be a better fit because it is more intensive with weekly visits. I've invited testifiers today from the evidence-based home visiting models which are in use in Nebraska to speak after me to give you a better understanding of how they function, who is eligible for the programs, and how they're funded. Home visiting has a long history in Nebraska. In fact, if you speak with our public health departments, they were conducting home visits for new mothers decades ago, a practice that was lost in an era of budget cuts. The first legislative effort in the unicameral was in 2007, when then Senator Gwen Howard passed a bill to allocate $600,000 for nurse home visiting services. This line item has remained in the budget bills annually and has since increased to $1.1 million. In 2010, the federal government created the Maternal, Infant, and Early Childhood Home Visiting Program, or MICV, as it's pronounced. That was authorized for 5 years and sent out base allocations of funding to states to increase access to home visiting services. The MICV program has consistently been reauthorized by the federal government due to broad bipartisan support on the federal level and is anticipated to be reauthorized again in December of this year. I've invited Sarah Howard from First Five, Nebraska, to give the committee more insight into the MICV reauthorization and what it might mean for our state. Excuse me. In closing, home visiting programs in the state of Nebraska are doing incredibly important work for our youngest children and families. Often called the silver bullet for child abuse prevention, a robust and coordinated home visiting network in Nebraska can not only improve outcomes overall for children, but particularly for those who are at risk of court involvement. After me, you're going to hear from organizations that are implementing home visiting in Nebraska, including the Nebraska Children's Home, a public health department, Sixpence, Early Head Start, and the VNA. And finally, First Five Nebraska will close with some statutory options to expand home visiting. I'm going to pass out a chart of home visiting models in Nebraska. Thank you, Senator Williams. I'm going to pass out a chart of home visiting models in Nebraska that will help you follow along as our testifiers come up. I appreciate the committee's time and attention to this issue, and I'll be happy to try to answer any questions that you may have. Though I would encourage you to ask the experts behind me, especially in light of the fact that my voice is about to go.
We'll help you with that. Are there questions for Senator DeBoer? You mentioned a senator that brought legislation earlier. I think you said it was Gwen Howard. Is she the mother or much older sister of Senator Sarah Howard?
I believe the young aunt of Sarah Howard.
A young aunt. Oh,
Yes.
now I understand.
Yes.
Seeing no questions, we will ask the first testifier for LR 367 to come. Welcome.
Hello, thank you. Good afternoon, Senator Williams and members of the Health and Human Services Committee. My name is Lana Temple Plotz, LANATEMPLE-PLOTZ, and I'm the CEO of NCHS. NCHS is a statewide accredited child and family serving nonprofit with 3 core programs. We will actually be 130 years old next year. Our 3 core programs are family support, foster care, and adoption. Our teams provide a range of support to caregivers of all kinds, including relative and kin caregivers, prospective and post-adoptive parents, and birth parents, to connect them with needed resources for healthy development and family preservation. We provide home visiting services for parents of children birth to age 5 in Douglas County. And I will say that home visitation, universal home visitation, is one of our strategic aspirations of our plan. So we are very invested in ensuring that every family in Nebraska has home visiting available to them. Parenting is a difficult and stressful, no matter what the circumstances of the parent. I always tell folks who ask me that no one ever has a baby, looks at that baby and says, if I could screw this up, that would be totally awesome. Everyone wants to be a good parent. And so for us, home visiting professionals provide support and education, alleviate stress, and promote healthy parent-child relationships. Families get connected to home visiting services through a variety of ways, including self-referral, peer participants, maternal homes, HHS, and other community referrals. During a home visit, a family resource specialist meets with parents and young children to engage them in an activity or an assessment using a strength-based curriculum that guides each meeting to work towards goals identified by the parents. The family resource specialist is a partner for parents, providing connection to items such as diapers, food pantries, and housing, transportation, utility or rental assistance, and mental health services. And we heard in the previous testimonies for the previous LRs how poverty is such a factor when it comes to being able to provide for your families and being able to provide good parenting to your kids. Our history of supporting caregivers through home visiting has evolved over time, and our passion and belief in its effectiveness has only grown. NCHS began home visiting in 2010 with our Teen and Young Parent Program. And then in 2013, we began offering Healthy Families America, or HFA, as a federally funded MCV site in Douglas County. In 2020, we further expanded our HFA programs with a child welfare adaptation team designed to provide community prevention supports for alternative response families that have come to the attention of the Children and Family Services. And this was made possible by Federal Family First Prevention Services Act funding and TANF funds. We have 3 HFA teams and 1 teen and young parent team of family resource specialists. Last year, we served 153 participants in Douglas and Sarpy County. The programs are free to participants and voluntary, although eligibility criteria varies with the public funding sources. We use a mix of federal funds such as MCV, TANF, and FFPSA funds, and private dollars to provide our home visiting services. Each time we've had the opportunity to grow our reach in home visiting has been through increased public investment. Home visiting is a bipartisan and popular approach to promoting positive outcomes for families, and it's a cost-effective prevention strategy. National research has shown a return on investment between $1.80 and $5.70 for every dollar spent on home visiting. These cost savings are attributed to reduced incidents of child maltreatment and child protection involvement, fewer children requiring special education or repeating grades in school, and lower criminal justice expenses. We have prioritized advocating for expanded access to home visiting within our 10-year strategic plan because we believe in its effectiveness and potential to truly partner with families to provide the supports they need to be successful. NCHS aspires to see all parents have access to home visiting in Nebraska, regardless of income or zip code, through a robust mixed delivery approach to pregnancy, early childhood, and parenting. Thank you, Senator DeBoer, for introducing this interim study, and to the HHS committee for holding this hearing. I'd be happy to answer any questions that you have.
Thank you. Are there questions? Seeing none, thank you for your testimony.
Thank you.
Invite the next
I
testifier.
was supposed to jazz you up, did I? Did I wake you guys up at all?
You might. At least you didn't mention Gwen Howard in your testimony. Welcome, Ms. Lopez.
Good afternoon, Senator Williams and committee members. I have a few comments to make. I am Pat Lopez, P-A-T-L-O-P-E-Z, and I'm currently the health director at Lincoln Lancaster County Health Department. And I want to share some information with you today about our Healthy Families America program that you heard a little bit about in Family Connect's home visitation program that we provide. The Healthy Families America is the signature home visiting program of Prevent Child Abuse America. And it's the nation's oldest and largest organization dedicated to the prevention of child abuse and neglect. And these services are provided to pregnant women or parents of an infant under 3 months with identified risk factors. And you have some in-depth information provided to you in a letter by Kim Engel, who's our director in the Panhandle about this. But I want to give you a little information about our program. Our department began implementing the evidence-based Healthy Families America program in 2012 after a 2-year pilot program. The program has been accredited since 2014 and was reaccredited in 2018, and we will go through a reaccreditation again in the spring of 2023. A few data points for consideration specific to our program in Lancaster County is that since its inception, we've provided an average of 4,400 visits per year to address the varied needs of families, ranging from access to care to providing employment resources. An average of 87% of our Healthy Families America families initiate breastfeeding compared to and sustain, compared to 85% in Nebraska and 83% in the US. And an average of 94.2% of children are connected to a medical home, and 89%, almost 90% of mothers complete their postpartum visit within 6 weeks. And 98% of our families have implemented safe sleep practices. And I want to just share a couple of real life examples that are not atypical of the outcomes from this program. We visited with a single mom who had no support from the birth father. The infant was placed in neonatal intensive care after birth for seizures and a possible mini stroke. Public health nurse began home visits and monitored the infant's development, and the infant began to show developmental delays at the 12-month screening. The public health nurse referred the family to early intervention services at Lincoln Public Schools. for an evaluation, and they began receiving services. Since receiving those services, there has been an improvement in meeting all developmental milestones and no further delays. The mother is now working in a long-term care community, which has enabled her to become self-sufficient. In the next example, we worked with a new mother for the past 2 years, which may seem like a long time, but it really isn't in the life of our youngest community members. One of her goals was to complete college, but she let this goal go after getting pregnant because she didn't think she could achieve it. After starting Healthy Families, her home visitor helped her re-enroll and start classes again. Together, they found her an internship that was needed to complete her bachelor's program. I'm so excited to say that in August of this year, she graduated with her bachelor's degree in education and human services and has secured meaningful employment and is now self-sufficient and able to take care of her child. Our funding for Healthy Families America program has been and continues to be through a braided funding model, which Senator DeBoer mentioned. So the McPhee funds, and then the Family First Prevention Services Act and TANF, which I know the committee is very familiar with. And we also are very fortunate to have city-county funding in our community that supports this. The second program I'd like to speak with you about today is our Family Connects home visitation model. This is a program that was developed from Durham. It's a new program for us. We just received funding in our current budget, and that was approved by our city council and county board. And we're building that foundation for the program now. We recognize that bringing home a newborn can be a challenging time for any parent. Our Family Connect services will be provided regardless of geography, economic or educational status, demographics, or previous number of children. It's open to all parents of a newborn. This evidence-based model, as I said, was developed in North Carolina. And I was one of those nurses, Senator DeBoer mentioned that a long time ago, I'll date myself, in public health, visited every parent of a newborn in my area here in Lancaster County. So I have a great passion. I'll finish quickly.
You've earned the right to finish your full testimony.
I'm very cognizant how long you've been here today. Home visits are provided by a registered nurse within the first 3 weeks of birth, and 1 to 3 visits are provided. The family's connected with these resources, and some people will ask about why is it a nurse? Well, this is really focusing on the health of the mother and the newborn. So there will be blood pressure screening, postpartum depression screening, and ensuring that women are following through with their OB provider and continue to receive the care that they may need. And the same is for the infants. You can read my testimony. But it's critical in connecting them to their healthcare provider and other services that will be needed. We'll do breastfeeding and nutrition support. And we also look at the social determinants of health. And I know you senators have heard that word and are familiar with that often, but we know that is looking at poverty and all other kinds of areas. We were asked frequently by our city council members sometimes about why didn't we just focus on one segment of parents, maybe those who had the most need. And I think the critical thing is that every family, I just want to emphasize that, is vulnerable at the birth of a child. And so it's really important that we reach every new parent, and we have other mechanisms that we can refer people to. So we do the caregiver child interaction assessment and coach and provide parents with supportive care. And for us, it really will work well because we do have McPhee here. We have Healthy Families America. So if families need more intensive assistance, we can get that provided for them. Family Connects, as we call our program, has been implemented in 17 states and over 40 communities. And that's Iowa, Illinois, Arkansas, and Oklahoma, to name a few, to give you a point of reference. And all of the 94% of the families in Family Connect have been reported to have received and followed up with at least one referral to a community-based organization. Our other local health directors see this as a need in their areas to support positive health outcomes for mothers and infants that has a lasting impact, and we are excited that we are able to offer support to all parents and newborns in our community so they have a strong start during this critical time. Thank you for your time and attention as you consider the important role home visitation has in the health outcomes of mothers and our youngest community members. Thank you.
Are there questions for Ms. Lopez? Senator Murman.
Yeah, thank you for your testimony. I don't know if you were here for the earlier hearings, but we heard that the more connections that a family has with HHS or with services, the bigger the chance are that children will be removed from the family. Do you have any ideas on that?
You know, I heard some of that. I didn't hear all of it because I was at another hearing, but I have to say I have the exact different opinion from my work actually in the field and working with families. What we've done is really prevent families from having that situation. And, you know, I can share something that happened early on in my time. I was working with a family and there was a situation of child abuse in that family, but with the intervention with that family, they went on to be extremely successful. And I ran into the mother about 5 years later, and she had finished her education and was a clinical social worker working with other families. So we rarely, our goal is to keep families together. And by doing this at an early point when families really need the support, Senator Mervin, that's where we found that we can make the biggest difference in prevention.
Okay,
that's really what we're doing.
Thank you.
Any additional questions? Seeing none.
Thank you.
Ms. Lopez.
I'll miss you, Miss.
Invite the next testifier for LR 367. Good afternoon and welcome.
Good afternoon. Long afternoon for you, like all the time. So, good afternoon, members of the Health and Human Services Committee. My name is Karen Pinkelman. That's Karen Pinkelman, Pinkelman. I'm the Associate Vice President for Early Childhood Programs at Nebraska Children and Families Foundation. I currently work on the team providing technical assistance to prenatal through age 3 grantees. Through partnerships with school districts, which makes us slightly unique, Sixpence serves 1,400 of Nebraska's children in both center-based care and home visitation. I'm here today to speak in support of Sixpence Parents as Teachers home visitation programs throughout the state. The first 3 years of life are especially crucial moment in young children's development. During this period, the human brain creates as many as 1 million new synaptic connections per second as neural circuitry is laid for new cognitive, social, and behavioral skills. Because of this rapid brain growth, the relationships, interactions, and environments that very young children experience, even in the prenatal months, can profoundly affect their lifelong trajectories for better or for worse. These experiences play a crucial role in determining whether children arrive at their first day of kindergarten ready to learn alongside their peers, development social positive behaviors as they grow older, and eventually take their place as productive members of the communities. Sixpence works with the school districts. One of the big things that Sixpence does is they have teen parents within that school district, so they have a higher graduation rate. They work with school counselors to ensure that they have college set up or they have post-secondary education. And when I was listening to your question before, as far as home visitation programs, I think they really are an alternative to Child Protective Services because they're voluntary. And so some of those families who need those connections and need those supports are asking for them before Child Protective Services get involved. And so it really is a preventative measure before those children get replaced and placed out of the home. The nice thing about Sixpence programs is we have community partnerships. So it really connects that school district with the community members and community partnerships and all of the resources that are available. It's a big part of the Sixpence grants, and the school districts have to match Sixpence funds by 100%. So it also educates parents about their infants and toddlers' needs and coach them on techniques to meet those needs. Sixpence enables parents to finish their high school degree, attend college, and pursue employment to best provide for their families. It helps families get economic stability and also helps them to have services, make sure they have health insurance, children have immunizations, and that they are on the educational trajectory to have be ready for kindergarten. So I think I'd like to thank you for giving me this opportunity. If you have any questions, I sure can answer them.
Are there questions for Ms. Pinkelman? I have one.
Yes.
In your home visiting program with Sixpence employees, are there mandatory reporting requirements to DHHS?
Yeah, everybody in the state is a mandatory reporter, so that if there is a cause of concern, then you have to, by law, report for children.
Any additional questions? Seeing none, thank you for your testimony.
Thank you.
Invite the next testifier for LR 367. Good afternoon and welcome.
Good afternoon. Let me get my glasses on. Thank you for allowing me to testify today. My name is Stephanie Knust, spelled StephanieKnust. I am the Nebraska Head Start State Collaboration Office Director, working within the Office of Early Childhood at the Nebraska Department of Education. My primary job responsibilities include encouraging collaboration between Head Start and other programs, services, and initiatives in the state, and facilitating the involvement of Head Start programs in state policies and decisions affecting families with low income. My role here today is to provide information about the federally funded Early Head Start program. Early Head Start programs provide intensive, comprehensive child development and family support services to low-income pregnant women and infants and toddlers under the age of 3 and their families. This is done either in center-based settings or through a home-based home visitation model, which is our focus today. Currently in Nebraska, approximately 45% of early head slots are funded for home-based home visitation services. During the 2021-22 school year, approximately 800 children and their families and nearly 140 pregnant women received home visitation services through Early Head Start. The full range of Early Head Start home-based home visitation services are provided through weekly home visits to each enrolled child and family by a certified home visitor. At a minimum, programs must provide 1 home visit per week per family that lasts at least 90 minutes, provide a minimum of 46 visits per year per family, provide a minimum of 22 group socialization activities, implement a high-quality research-based curriculum for infants and toddlers that promotes measurable progress toward children's development, observe and assess children at least 4 times per year for progress in specific developmental domains, and programs are also required to provide a research-based parenting curriculum and implement an individualized family partnership agreement process with families that involves goal setting. Additional standards and requirements exist in the areas of program governance, health and nutrition services, services for children with disabilities, transition services, and others. The Department of Health and Human Services federal poverty guidelines are used to determine income eligibility for participation in Early Head Start. Children from birth to age 3 or pregnant women who are from families with incomes at or below 100% of the federal poverty guidelines are eligible for services. Children from homeless families, families receiving public assistance, and foster children are also categorically eligible for the program. Federal funding for an Early Head Start program comes from the Department of Health and Human Services directly to local community entities known as grant recipients, of which there are 19 in Nebraska. The federal government funds community grant recipients at 80% of the total cost of program services, and then there is a 20% non-federal match requirement. Individual child outcomes data in several developmental domains is observed, assessed, and shared with parents multiple times over the course of a program year. And in addition, each individual program analyzes and reports aggregated child outcomes data to governing bodies and federal funders. Children enrolled in Nebraska Early Head Start programs consistently make gains across every domain of child outcomes assessed, including language acquisition, cognition, social, emotional, and physical development each year. Federal program outcomes in the areas of health, nutrition, disabilities, family well-being, and family self-sufficiency are also reported annually to Congress. And during the 2021-2022 program year, 95% of enrolled Head Start families received at least one program service designed to promote family outcomes, and 60% received some form of emergency crisis intervention, such as help meeting immediate needs for food, clothing, and shelter. Thank you again for allowing me to provide some more information regarding the Federal Early Head Start program, and thank you for your willingness to support home visiting in Nebraska. I'm happy to answer any questions.
Are there questions?
I did have one.
Senator Walsh.
I don't remember what it was. I'm pretty familiar with Head Start, but under the model and curricula, you talked about providing a minimum of 22 group socialization activities. I'm just not familiar with, like, what's an example of that?
Well, since we're implementing, or Head Start programs are implementing a home-based model where home visitors are going into the home, they're also required to provide socialization activities for the parents and children to come together at certain times for activities. So that's an opportunity for an activity where the parents can get together, learn something that they're interested in, work on some of their family goals that are in common, and then parents and then children also have a chance to socialize.
And that's within the home or
No,
outside
it can,
the home?
well, it can be anywhere.
Okay.
Lots of places have them in centers or parks or other places in the community.
Okay, good. Thank you.
Any additional questions? Seeing none, thank you for your testimony. Invite the next testifier for LR 367. Good afternoon and welcome.
Hello. My name is Sandy Spicciati, SANDYSPICCIATI. Spicciati.
Okay.
I am here representing the Visiting Nurse Association, which is entering our 126th year of serving Omaha and surrounding communities, providing community health services, including home visitation services to vulnerable and under-resourced families, parents, and children. Thank you, Senator DeBoer, for introducing Legislative Resolution 367. Visiting Nurse Association supports the need to study early childhood home visitation in our state with the potential to expand home visiting services. As stated in the resolution, home visitation is a prevention strategy used to support pregnant moms and new parents, which promotes infant and child health, fosters educational development and school readiness, and prevents abuse and neglect. VNA offers 4 voluntary early childhood home visiting programs in the metro area. 2 are evidence-based models, Healthy Families America and Nurse Family Partnership. 2 are non-evidence-based models that utilize the Growing Great Kids evidence-based curriculum, Love and Learn Teen and Young Parent Program, and Project WIN. VNA, in partnership with One World Community Health Center, provides public health nursing or family support specialist visits in the in the evidence-based model, Healthy Families America. The eligibility criteria for HFA is the family must live in Douglas County, be 22 years of age or older, have low income, be pregnant or parenting a child less than 3 months of age, or have a child involved in the child welfare system under the age of 2. Additionally, families must score high on the program's risk assessment to be considered eligible. Funding for this program is provided through contracts and grants from Nebraska Federal McVie, Nebraska State General Funds, TANF, and private foundations. Our second evidence-based program is the Nurse Family Partnership. This is VNA's evidence-based home visiting model in Pottawatomie County, Iowa. Eligible participants in this program must be experiencing their first-time pregnancy and enrolled in the program prior to 28 weeks of pregnancy. The program is funded through contracts and grants from the Iowa federal McPhee funds and private foundations. Our third program is the Love and Learn Teen and Young Parent Program. This program offers a multidisciplinary approach with a public health nurse and a parent coach assigned to every family. This program utilizes the evidence-based curriculum, Growing Great Kids, and eligibility requirements include pregnant and parenting individuals under the age of 26 who live in Douglas or Sarpy County. The Love and Learn program is funded through contracts and grants from private foundations. Our last program is Project WIN, Welcoming Infants into Neighborhoods. This program provides public health nursing and may include a parent coach, home visiting, utilizing the evidence-based curriculum, Growing Great Kids. Services are provided to pregnant parenting individuals with a child under the age of 3. Services can be extended up to age 5. These services are, families must live in Douglas and Sarpy County in Nebraska and Pottawatomie County in Iowa. This program receives funding through contracts from Early Childhood Iowa and grants from private foundations. So you might be asking, why are you offering 4 different home visiting programs? Well, the answer is there is no one home visiting program that is appropriate for every family. VNA is a very strong proponent of the evidence-based models. However, many under-resourced families facing complex issues are not eligible for the stringent criteria of evidence-based models, but desire and need these critical and intensive home visiting services. For example, a 4-month-old infant may be seen in the emergency department multiple times for a minor health condition or health issue. This is the family's 3rd child under the age of 3. They are not involved in the child welfare system. The family would not be eligible for an evidence-based model, but would be eligible for our Project WIN program. This family would be seen by a public health nurse and, depending on the county, a parent coach, and an average of twice a month for approximately 1 year. The family receives health screening, assessment, parent education, parent-child interaction, coaching, and support for life skill development leading to a healthier family, reduced abuse and neglect, promotion of child development, school readiness, and improved self-sufficiency, all utilizing the Growing Great Kids curriculum. VNA is also part of a family support referral system in Pottawatomie County, Iowa, through the Child and Family Resource Network. A collective messaging and referral process is in place for individuals and communities regarding home visiting and other family support services that span across 9 counties in western Iowa. Having this streamlined system in place allows families to be referred to agencies based on their desires and needs without duplication of services. I'm not aware that Nebraska has a coordinated intake system currently. However, I would encourage further dialogue to consider implementation of such a coordinated intake process. At any given time, VNA home visiting programs can serve 270 families in Douglas, Sarpy, and Pottawatomie counties. Currently, we are near capacity in all programs, and we hold a wait list for our Project WIN program. I'm here today in support of the proposal for an interim study to examine home visitation. Any questions?
Thank you, Ms. Picotti.
Yes.
Further questions? I have one. Since all the members of our committee that serve a legislative district and work, live, and play where you work have deserted us this afternoon, What do you do in the rest of the state, or are there services, and you don't do it, but are there services in the areas that we serve that are available similar to what you do?
Absolutely. You received a map today, and that highlights all the home visitation programs throughout the state. In our area, in Omaha and Council Bluffs area, if we have a referral for someone or working with a family who is moving to a different area in the state, we have connections with different home visitation programs that we can refer them to.
Okay. Any additional questions? Seeing none, thank you for your testimony.
Thank you.
Invite the next testifier for LR 367. As Senator Howard is coming up, I would ask, are there any other testifiers following Senator Howard? If not, then don't bother to turn the lights on.
All right, let's do it. Okay. Make sure I have everything.
Welcome, Senator Howard.
Thank you, Senator Williams. Thank you for allowing me to testify today. My name is Sarah Howard, S-A-R-A-H-O-W-A-R-D. I'm a policy advisor for First 5 Nebraska. First 5 Nebraska is a statewide public policy organization focused on promoting quality early care and learning opportunities for Nebraska's youngest children. My position at First 5 is focused on the area of maternal and infant health policy because we know that healthy moms and babies are critical to ensuring the long-term success of children in our state. I'm here to testify on Senator DeBoer's interim resolution LR 367. And first, I want to thank Senator DeBoer for her interest in home visiting in the state of Nebraska. This is really exciting because it's the first time that this legislature will have really considered home visiting. So I'm going to give you the statutory sort of background on home visiting. And then we're going to talk a little bit about the federal reauthorization bill for McPhee. Okay, so all the way back in 2007, my mom introduced a bill to in the Appropriations Committee to fund a nurse home visitation model. So you guys probably remember my mom was a social worker for the state of Nebraska for 34 years. And when she started to learn about home visiting programs, she realized that people are more likely and interested to let a nurse come into their home before they would ever let a social worker come into their home, because it's very likely that a social worker is going to remove your kids. And so she was able to get $600,000 in the budget for nurse home visiting. Well, then when I got here, I wanted to increase that amount. And so I put in an appropriations bill, and the state of Nebraska asked me if I would remove the nursing piece. So then the language of the appropriation actually changed to evidence-based home visiting, which kind of opened it up to all of these different types of home visiting, similar to what you've heard about today. And that allocation has since increased to $1.1 million. And it sits in the baseline budget. So all of you here have already voted for home visiting. You're welcome. And thank you for that. So remember that 1.1 million that sits in the budget, because now I'm going to talk to you about the federal allocations under the McPhee program. So the Maternal and Infant Early Childhood Home Visiting Program is a federal program that has to be reauthorized every few years. And it was actually just voted out of the House of Representatives this morning, which is really exciting. The entire Nebraska delegation voted for it, and Representative Smith actually co-sponsored it, which is really exciting. McVie is structured in a little bit of a different way than most of our federal programs, in the sense that it's a baseline. The states just get a specific amount. We don't have to kick in anything, right? You remember for Medicaid, we've got an FMAP. For SNAP, we've got to pay for some of our admin expenses. For McVie, we just get $1.2 million, and we just continue to get it over the course of the reauthorization for 5 years. With the bill that was voted on in the House this morning, we'll be getting $1.7 million annually. That's just our base amount for home visiting, which is super duper exciting. However, that 1.1 million that we have in the budget now becomes maintenance of effort. So we're not able to go below that 1.1 million anymore without potentially seeing a penalty. The other piece that comes out of the new federal McPhee bill, and this was something that Adrian Smith in particular and the conservative members of Congress were very excited about, is that there's actually the opportunity for states with a matching dollar amount. They can grow their programs and they can grow the amount that they're pulling down from the federal government for home visiting. That's at 25-75%. It is late on a Friday. You are not going to remember it. It is in my testimony. But for our purposes, if we want to grow our home visiting programs utilizing federal dollars, in 2024, we would need to find about $250,000 in the budget in order to draw down about $750,000 from the federal government and grow our home visiting programs. As you can see from this handout, this is our little map of McV funded programs. These are only McV funded programs. Your other map is programs that are home visiting programs that are funded by a variety of sources. This is only McV. If you flip it over to the back at the top, you can see how Nebraska in particular is braiding funding around home visiting. So not only are they using the federal McV funding, but they're also using those state general funds, the 1.1 I told you about, and we're using those TANF rainy day funds, which I know this committee is very familiar with. So right now we're going to see increases of TANF rainy day funds, and that's an allowable purpose. What you've heard from some of our testifiers is that we're also starting to use Families First Prevention Services dollars, or FFPSA dollars, to pay for home visiting. And that's because now we'll be able to, that is an allowable use of FFPSA dollars. So the question that you would ask me would be, what are our statutory options in order to increase access to home visiting in the state of Nebraska? So the first one is similar. You all were there. When we were dealing with the YRTC situation, we went in and we said, well, sure, we'll just check the statutes. There's got to be a statute. And there was no statute, right? And so all of us had to put together a statute around what a YRTC is and what our state expectations are for youth rehabilitation and treatment centers. In Nebraska, there is no statute for home visiting. We've never defined it. We've never said what our expectations are for the way that we use state dollars around home visiting. So your first step as a legislature, and your first logical step as a legislature, would be to define what home visiting is in statute and build out your own statute around home visiting. The second thing I would recommend, and this is sort of, it goes back to Sandy's thoughts around a coordinated intake. The second thing I would recommend you do is ask DHHS to create a website where all of the evidence-based home visiting models you can access or find out where they are at. Just a website. It's all in one place. Right now, if you look, you can see where the McV funded programs are, but you're not able to see our Sixpence programs, our VNA programs that aren't funded by McV. And so it makes logical sense that we would also consider having a website, and that would become the base for what would look like a coordinated or centralized intake system for home visiting. The last two pieces are financial. One, if we're smart, and you guys definitely are, I would recommend taking that 1.1 million that's currently in the budget every other year and moving that into statute so we know that we never go below our maintenance of effort. The other piece I would recommend that you consider is increasing that allocation or that amount by about 900,000 so that over the course of this next reauthorization, we'll maximize all of the federal dollars that are available to us for home visiting. So you're looking at a fiscal note of about $2 million. That being said, home visiting is, and Senator DeBoer said it best, it's really truly considered the silver bullet for child welfare. It's when a family is at risk, but it's not time for a call to the hotline, right? Maybe I have some concerns about where their next meal is coming from. Maybe I have some concerns about mom not quite knowing how to parent well or something along those lines. Home visiting is a support that you can provide to a family before they ever get a call to the hotline. It's sort of, in other states, they call their coordinated intake for home visiting a warm line, which is kind of what you would like to see, right? It's a warm line for families and a support for families before they ever get to the urgency or the crisis level of a hotline call. So with that, I really appreciate your time and attention on a Friday afternoon to home visiting. It is a really lovely program, and it's a really lovely system and opportunity that we have in our state, and I'm happy to try to answer any questions you may have.
Questions for Senator Howard? Senator Walsh.
I don't really have a question. I just thank you for coming to testify. You are a really smart person, and I think you should run for the legislature.
They're not letting me do that anymore. They kicked me out.
Well, I do have some questions.
Real ones.
It is on the additional funding, the 2575 match, is there any cap on that?
So it's a set amount that we are eligible for. Okay. So if it goes up over the next 4 years. So it starts at about 250,000, and then we are capped out. So
and in your financial request or thoughts down here, you would be going to whatever that.
I would get us to our max over the course of the 5 years.
Second question, here we are December 2nd with legislative session starting in about a month. Do you have a plan to have your 1, 2, 3, and 4 put into a draft of legislation that you might find somebody that would introduce?
Yes. Yes. Senator DeBoer
I've never
has been
had
working
you
with me on a
answer a
draft.
question with one word.
Yes, yes. Although, yes, yes.
That was 7 yeses now. Are there any additional or final questions for Senator Howard?
No.
Thank you for being here.
Thank you for your time today. I really appreciate it.
Are there any additional testifiers on LR 367? As Senator DeBoer is coming up, then we do have, again, online comments from Nicole Barrett, Izzy Lopez, and Jesse DeWally. Senator DeBoer, welcome.
Thank you, Senator
Again.
Williams. I'm just going to take a moment. We're going to miss you next year, Senator Williams. So I just wanted to say thank you to everyone who came up to testify today. I think this was helpful. And to everyone who's been helping to educate me about this really important topic of home visiting. We address so many problems in this building that it's really hard to see how can you get at these big problems that we look at these built in this building. So to have something that has such a positive impact for, frankly, not a terribly large amount of commitment from the state is the kind of thing that I think we always look for and never think we're going to be able to find. So I think this next session and going forward, we're really going to have to look at doing more with home visiting. I mean, it gets bipartisan support everywhere. This is a good program. It does not, as far as I know, have a substantial pushback against it. So I hope we can continue to work on home visiting in Nebraska. Thank you.
Any final questions? Seeing none, thank you, Senator DeBoer, and that will close the public hearing on LR 367 and close our hearings for the day and I believe for the year, right?
Yes,
Bryce?
that's correct.
None other.